All right, so I've got the record button on.
I'm a volunteer.
Oh, me too.
And we're gonna have a nice conversation. So I've still got about a minute or two left before we start, but I wanted to make sure that the recording was set up and working for us. Kelly, good morning. Can you hear me, Kelly? I can't, you can hear me, but I can't hear you. Is that what's happening? Try logging out and logging back in again if you can't be heard, or checking to see if you're on mute. Dr. Schmiegel, how are you? Welcome.
Hi, nice to meet you too.
Meet you as well. You as well. Thank you for joining us today. All right, I was just doing a little bit of housekeeping. We've got people starting to kind of come in. I am recording this so that we can have this as a training opportunity for those who aren't able to attend. So just to make you aware of that, we will be talking and discussing. And when I run this new higher version of the Alzheimer's training, I like to have a lot of discussion. So I try to make it as interactive as I can, but I'm also cognizant of our time. We have 3.5 hours to get through what normally takes about 8.5 hours to complete. So I'm going to do the best I can to expedite and keep us rolling through, but we are going to be focusing in on some really important aspects of our practice, the things that we are going to see. And we've got a really good group today. We've got kind of a mixed bag. We've got professionals. Now, I'm not going to say you're not all professional, because you're all professionals. But we've got folks from the chaplaincy. We've got folks from the volunteer group. We've got folks from the CNAs. And clinically speaking, we have physician in the house. Hey! And we've got nursing as well. So we're well represented across the spectrum. I'm really excited about this. There you are, Kelly. Hi there. I'm just Kelly. Can you speak for a second so I can hear if your microphone's working? Cal, can you hear me? Kelly? Kelly, can you hear me? I don't think she can hear me. I don't think she can hear me. Okay. Kelly.
Write something on a paper.
I know, I've got to write something on paper. That's good. That's a great idea. Oh my gosh. Here we go. First icebreaker. How to communicate when the electronics are down. No.
Read it backwards. Oh. That's right.
Kelly, can you hear me?
Yes, I can now. Sorry, I couldn't hear you before. Good morning.
Wow, that was amazing. Okay, thank you.
You're
Megan,
welcome.
welcome. Can you put your camera on, darling? I need to see your smiling faces, all of y'all. Not the one on your profile, Megan. Wise guy. 20,000 comedians out of work. All right. So I appreciate you all joining us. As I was stating before, we are recording for those of you who just came in. And we're going to be talking about Alzheimer's disease, but we're also going to be talking about something called habilitation therapy. And one of the amazing parts of our practice in taking care of folks, whether it's end of life, and most of you are here because you work in the supportive care section of the VNA. If it's end of life, we have more than just the patient that we are recognizing in our care. We're also caring for the caregivers and being able to learn about the disease process, how that's affecting the patient and how that's affecting the patient's family, and how we as caregivers can come in and use our expertise to kind of help that patient at the place where they're at. See, habilitation therapy is not going to make your patient any better. It's simply going to meet them where they live, where they are existing right now. Does that make sense to everybody? Megan, I need your camera on for compliance, my friend.
It's Mary there.
Her name's Megan. Mary Megan Schwego. That's okay. She's trying. So what I like to usually start out is kind of going over a little bit of what we're going to be talking about today. Now, just some housekeeping things. So for you guys, for everybody that was invited to this, I gave you a lot of information that was attached to that email. You're not being tested on all of that today, I promise you. Okay? It wasn't a crash course in Alzheimer's pharmacology or anything like that. But because we have nursing present, I wanted to make sure that some of the latest medications and patient education information was available to you. And we're going to briefly touch on that as we go through this discussion and this training on Alzheimer's. I also had put in there the state regulations that dictate practice. Just make sure you guys sign in. Thanks. That dictate practice, and why is it so important to have this 8 hours in the state of Massachusetts? Well, the state of Massachusetts requires that every licensed professional and every person who's going to work with the elderly population has the opportunity to get to be given education in regards to Alzheimer's and dementia, simply because this cycle of life is what we're dealing with quite a bit within the scope of our practice. So if we go into a long-term care facility, 9 out of 10 times we're going to go in and we're going to see someone who is being affected at some level by Alzheimer's and dementia. Okay, so we need to be able to be in compliance with what the state says, and I provided that statute for you guys to have. I also provided some other information that I really wanted to kind of go over real quickly. I'm doing things a little bit differently today than I usually do, because I did include a lot of information, and some of you probably went, ah, oh my gosh, how many trees did you have to kill for that? Well, I didn't kill a lot of trees. I just put it on electronic PDF format so I wouldn't have to, right? So what I did include in there was also this, and this is the NIH Alzheimer's Disease and Related Dementias Research Progress Report. Now, for those of you who are lay people in here, this is probably not going to be all that interesting. As a matter of fact, it's probably going to make your head hurt to go through a lot of this information. However, here's a really fascinating part of this. This report compiles all of the research, all of the medication, and all of the testing and support information that is happening surrounding Alzheimer's research. And it's as of 2025. So I wanted you guys to have access to this, because this is the latest and greatest as to what is going on in the field of treatment. Does that make sense? Okay, cool. This is really good, especially if you have a loved one who you are dealing with the trauma of Alzheimer's or dementia and its progression within your loved one. This gives some information on some of the new strategies and the new things that are out there. I was amazed when I was looking at this report, how many different approaches are being made to try and address the progression of Alzheimer's. trying to get into a place where we can actually get a handle on it. And the difficulty with this disease is that a lot of times it's layered in with other factors that are causing the dementia, right? So it may not be just one causative factor. There are specific genes that people carry that make them more predisposed to developing Alzheimer's. And we're going to talk a little bit about that too. But the therapies that are being developed right now and the strategies that are being developed based upon an understanding of how this disease works, and it works differently in different people. That's the challenge. Come on in. Welcome. That's the challenge. So I thought this would be an interesting reference guide for you guys. Please use it. Let me know how you feel about it, what your thoughts were on it, because I may be referencing this a little bit today, not a lot. This is going to be kind of a sky-high view of Alzheimer's. This, as I said this earlier, this training is usually about 8 hours long, okay? What we've done is we've broken it down into about 3.5 hours of classroom, and we've given you guys the opportunity to do some of the coursework on Relias. So, or we've got alternative opportunities for you guys to be able to be compliant with the state standard. So I did send out, along with that email that I sent out for the volunteers, and this is specifically for the volunteers, you do not have access to the Relias education platform that we have at South Coast. So what we have is a tool that allows you to go in and watch videos that are going to help bring you up to speed and satisfy that requirement. So being part of this group satisfies the in-classroom. Taking a look at that outline and the videos that are on there, that completes the other requirements. So if you are a volunteer, and this is specifically for volunteers, please take a look at that. If you have questions, don't hesitate to reach out to myself or Judy, and we will help to answer those questions as best we can. Does that make sense to everybody? Okay, that was a huge, long preamble, right? And I took only 10 minutes to do it. Yeah, all right. So, a couple other things, housekeeping things that I'd like to talk about right now. First of all, are there any questions about anything that was sent to you that I can clarify now? You guys are all good?
Mhm.
Everybody's good?
Yes.
Perfect. All right. So let's talk about Alzheimer's. And I'd like a show of hands as to how many people in this group are actually dealing with this or have dealt with this on a personal level. Like you're taking care of a patient who may be somebody that you know, or it's a family member. How many of you have had that experience? So some of you have had family members who have been afflicted with Alzheimer's. How many of you have had family members who have had different types of dementia that have been layered in? Right? So here's the next question. How many of you have professionally been dealing with this disease or a variation of this disease in your experience? Yeah, everybody in here is going to raise your hands for the most part. How many of us have long-term care experience? For sure. If you've had any exposure to long-term care at all, you're going to see that this disease is prevalent in a lot of the aging population. We're going to see how this affects people in the later stages of life, but it can also affect people in midlife as well. So we're going to talk about all of those factors, and I'd just like to ask a question for the whole group, and you guys, as you feel moved to offer an answer, and that's for those of you who are watching this online as well and being a part of this online. What was if you had one significant challenge that was raised as a result of this disease, and I'm saying Alzheimer's and / dementia, what would it be for you personally? What is the challenge personally for you? Patience. Okay, is that P-A-T-I-E-N-T or P-A-T-I-E-N-C-E?
I think,
Oh, okay. Can you tell us some more about that?
I think is if you are caregiver to that person, not that I have had personal experience, but I've had professional experience. Sometimes the behavior and the way that they are trying to communicate, they're frustrated, and then you have to hold yourself so that you're not going to be frustrated.
So what I hear you saying is that emotionally speaking, even if the person is not necessarily a family member, it's still hello. Hello. Who's our four-legged furry friend that's joining us today? I would ask you guys to please keep your mutes on, just because I love the dog. What's the dog's name, Kelly?
It's Ziggy. He hears me
Okay.
upstairs, that's why. Sorry.
Right, Ziggy, raise your paw next time. All right.
I know. I'm trying to put
So-
it on mute, but I don't know.
Yeah, if you can put your mute on, that'd be great.
Okay, yes.
Thank you.
You're welcome. Try to do it now.
You can definitely talk, Kelly, okay? Just Ziggy's been talking more than you are. Okay. So to address what Melissa was just hello. The mute button should be down on, it should be on the bottom or on the top, depending on what you'll, there you go, girl. All right. So getting back to Larissa's comment, this is an emotional component to this disease process, both for the caregiver and for the individual. And having the patience, does that happen automatically?
Like intentional in a work process. I think
It's developmental, right? We don't come across as being experts right away. We have to, we have some experiences that we have to learn from. And this is kind of the way we look at this training, is to give you kind of a foundation so that the more you understand the process of what's going on, the better it's going to be for your patient's family, for you. And when you have more information and wisdom to use it, you become a more patient person because you don't react, you respond. Does that make sense? Awesome. Awesome sauce. All right, so we're going to talk a little bit about disclaimers, conflict of interest statement. The planners and presenters have no known actual or perceived conflicts of interest to report. So this is some of the objectives that we're going to try to address as we go through this training. And I will be giving you guys a break to get up and stretch a little bit, because 3.5 hours sitting here, you're going to be stage oneing all the way out. So I want to make sure that we get up and we're moving around and get the circulation going, okay? Understanding how the actual process works. Now, here's something it's interesting and why it's so important for you guys to send me the evaluation. I learned from the evaluation how to better present this information, okay? Not everybody wants to sit here and hear me go, wah, 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 right? And certainly, if it's not applicable to you, then you don't necessarily want to hear all that. So what I'm going to do the best I can to do is I'm going to give you a snapshot, but we're going to keep it moving, okay, of how this works. I tend to be, I was anatomy and physiology educator. So I get excited when I see the A and P of this. And sometimes I spend a little too much time on that. So I'm going to endeavor to try and bring us through that, but get us to the place where it's actual practical application for us. And that is really the habilitation piece of this. It's understanding the person you're dealing with, what their challenges are, and how we have strategies that we can help them where they're at. And we can also help their caregivers to be able to interact with them and support them and feel supported as well. Does that make sense to everybody? Okay. Learning communication skills to enhance verbal and nonverbal interactions. I'm not going to pretend that I think that anybody here, because I saw the hands raised, you've all had some experience with this, yeah? Some of us have had decades of experience with this. So I'm not going to try and recreate the wheel here, but I do want to build on that experience, and I do want us to have some conversations around that. So understanding the causes of difficult behaviors. Why are they acting the way they're acting? Again, that gives us a really good foundation for patients, right? Learning a person-centered approach to dementia care. That's huge. We are not treating a disease. We are taking care of a patient, a person. And sometimes it gets really difficult to separate both, doesn't it? Yeah. Recognize and respond to caregiver stress. We don't get stressed, do we? Come on now. Do you get stressed? Never. How dare you utter the thought? Well, guess what? We're human beings and we get super stressed when we get overwhelmed. And to get overwhelmed emotionally will cut off the upper reasoning of the brain and we go primal. And that stress now manifests in a lot of ways. Sometimes they're productive, they're not productive. Sometimes they're really, really destructive. And eventually what happens is we wind up bringing that to our patients. It's not good, right? So your caregiver stress is for real. We're going to talk about learning about diet and nutrition needs. And I found some fascinating insights in the NIH report about lifestyle and diet in regards to prevention of Alzheimer's and dementias, okay? Fascinating information having to do with HDL and LDL intake, balancing out nutrition so that it's less on the carbohydrate heavy scale and more on a balanced scale, with carbohydrates taking a smaller segment of that. For me, nutrition, that's another thing that really excites me. So please forgive me. I'm going to woosah a little bit. Okay. But it's speaking my language. Learning therapeutic activities and socialization. So one of the pieces of documentation that I provided to you guys in that email correspondence was this. This is an activities for people with dementia. This is an awesome, awesome resource for you as a caregiver, but also for our caregivers who are in the home. This has a lot of really great ideas on how to help intervene and keep busy that individual who may not be at the later stages of Alzheimer's, but they're still in those early stages, early to mid stages of development of the disease. These are really good activities that can help them where they're at. And it can also be a real bonding experience for the family as well. Window boxes, things like that, activities, things like that. So this is going to be a really good resource for you. And then finally, we talk about preventing, recognizing, and responding to abuse and neglect. How many of us here are mandated reporters? Every last one of us. When we walk into that home, what we see, if we see something that doesn't look right, it doesn't smell well. I stopped myself there, but if it doesn't look right and it doesn't pass our litmus test for quote unquote good behavior, then we need to report it, even if we have a suspicion. It's not personal, but it is our job. And we're going to talk about that as well. Any questions so far? All right, so we're going to rock and roll now through this. So first of all, dementia is a symptom. There are so many different facets to this term that people get locked in and they automatically stereotype the individual that has had this diagnosis without even figuring out why do they have the diagnosis. They just go right to that place where they must have Alzheimer's. That's not the case. A lot of times dementias as the symptom, it's going to be the best way to explain a connecting point to another disorder or disease. We have a bunch of them that have been in the news recently, right? So let's just talk about the ones that we have in front of us. So dementia is actually the umbrella term, and it's it's basically describing a range of symptoms that are associated with cognitive impairment. Cognitive impairment being, how do I interact and how do I perceive what's coming into me communication-wise, like hearing, seeing, smelling, speaking. Those are all cognitive. What thoughts am I forming? Those are all cognitive things that we do in our brains, but this now interrupts that. So Alzheimer's accounts for about 50 to 75% of all of the dementias. That's significant. Hence the reason we're having a training on Alzheimer's, right? Then there's vascular dementia, which is about 20 to 30%. And then we have Lewy body, which is 10 to 25%. And then frontotemporal dementia, which accounts for about 10 to 15%. Now, we're just giving you the quick outline of this because we're going to go into each one of these and kind of describe what they're about. Does that make sense to everybody? Okay. So we'll talk about some of the causes. We look at Alzheimer's disease, and you're going to see me reference in my cheat sheet here because I can't keep this all in my brain. And people way smarter than me developed this, so we're gonna continue to reference this. So we talk about Alzheimer's disease, which is the most common, and again, sometimes mislabel patients. Well, they have Alzheimer's when they actually have dementia. Maybe they've got Lewy body dementia. Maybe they've got a vascular dementia, and vascular dementia, we're going to talk about that, has to do with the plumbing in the brain. How does blood circulate in the brain? Little blood vessels, right? When those little blood vessels go, we wind up having insults to the brain that interrupt the flow of information, right? If you have that happen in enough parts of the brain, that can lead to a dementia diagnosis. Okay, and we're going to talk a little bit more about that as we go on. And that's, again, the second part here is vascular dementia, multi-infarct or post-stroke dementia. Those are those patients who have had what we call a TIA. Does everybody know what a TIA is? What's a TIA? Transient ischemic attack. Simply meaning transient means it just happened, like it kind of moving through. Boom, there it is. Ischemic means it was deprived of oxygen. That blood vessel was deprived of oxygen. And it's an accident because it wasn't really meant to happen. It just happened as a result of either a small blood clot lodging in one of those blood vessels, or with a hemorrhagic stroke or similar TIA, you now have one of those little blood vessels that ruptures and causes a small bleed in that section of the brain. Well, still, the result is the same. You're depriving the brain of oxygen. Okay? We have mixed dementias that have more than one cause. And what you're going to find when we talk about Alzheimer's, which is pretty amazing to me, is that it's layered. The causes are layered. Sometimes we can treat some of those other causes that are layering in and overall increase the ability of that patient to have quality of life, right? But we have to find out what those things are. And sometimes, as lay people, we come in and we look at it and we just say, well, that's what it is. As a physician, gerontologist or a neurologist, someone who was dealing specifically with disorders of the brain, they're going to come in and they're going to look to see what are the other factors that are involved. Does this patient have some issues with their thyroid? Are they a diabetic? Are there other factors that are playing in here? And we're going to talk about those as well. We have Wernicke-Korsakoff syndrome, which is essentially a nutritional deficiency. Okay, but we see this related to, if those of you who are nursing in here and doctors know that Wernicke-Korsakoff, almost all the time we have this tied to what? Awkward silence. Alcoholism. Okay.
Vegans.
No, not vegans. No, not vegans. No. That's a good one though, right? No, that's not it. She said vegans, by the way. That was not cool. Thiamine B1 deficiency, right? Thiamine is a B1 deficiency. And when you think about that though,
I was thinking B12.
the B vitamins are really challenging for somebody who's in a vegan lifestyle, right? Wernicke-Korsakoff is actually a description of the areas of the brain that are being affected by that nutritional deficiency. Okay, so low thiamine causes inability for the brain cells to generate energy. And this is something that we understand as a part of our practice, is that a lot of these disease conditions, or these conditions here, more specifically with the nutritional deficit, can happen with a lot of our patients, yeah? What are the reasons why a person might have this layered in as a potential cause from a nutritional standpoint?
They have a history of alcoholism.
They could have a history of alcoholism, which means their diet is more focused on the alcohol than it is on real food, right? What else could be? Let's think more along the lines of, let's move off of the substance abuse, and let's look at the real factors. What else could cause this? A nutritional deficiency. How about chemo? How about radiation? How about malabsorption? How about all of those things that could possibly be contributing factors to why our bodies aren't getting the stuff they need? Does that make sense to everybody?
Yeah.
Okay. So we're going to break this down a little bit. We have Lewy body dementia, which is essentially associated with Parkinson's disease. Okay? And we need to really understand that there is a severe sensitivity to neuroleptic medication. And this is where I'm going to kind of tie in for our clinicians. This is important to realize when you're doing starts of care on patients who are coming in with a diagnosis like this. We need to make sure when we're doing our med audit and we're doing a med reconciliation, we're taking a look, and we don't have to do what the doctor's job is, but we do need to do our due diligence. If we see that that patient is taking a medication, a neuroleptic medication, and they have a diagnosis of Lewy body, that can be catastrophic. That will kill them. So we've got to make sure we kind of are up a little bit on our pharmacology. We know, and you guys have mugs, which is a really good resource for looking up medications, yeah? We also have something called LexiComp that is available to all South Coast employees, which is a really good reference guide as well. We have the frontotemporal dementias. Where do we hear this term being used a lot with familiar people in society today? Like famous people. Bruce Willis, right? So what is going on with Bruce Willis? What happened with him?
Can't talk. He's forgotten, but he can still walk around and wonder.
So his disease condition, if you've watched any of this at all unfold, and his family's been very transparent about what this journey is like for them as caregivers and what it's like for him. It's tragic, because it starts out with some memory loss, right? And then it progresses to aphasia. And aphasia is the inability to understand the spoken language, and you can't connect the meaning to the words. And that starts to be really prevalent. And then we see a continuing degradation of the brain's ability to function. That frontotemporal region is incredibly important for our learning and our understanding of communication. Things that are said to us, how we recognize people. So it's really important to understand that that particular disease process is making the headlines because somebody famous is going through it and they're willing to share this. We got other ones that had Lewy body. Who do we know who had Lewy body dementia and ended his life in 2014? One of my favorite comedians of all time, Robin Williams.
Oh, yeah.
Robin Williams suffered through this. In fact, his last movie, Night at the Museum, that second part, he was having some real challenges on set. As they look back on, his wife wrote an autobiography on her experience with him going through this. Absolutely amazing from the caregiver's standpoint what they see and how they deal with the stress of what's going on. So I would encourage you kind of do the research on it if you have the opportunity. And we've got some other opportunities as well for people that we're going to be talking about in this presentation. Creutzfeldt-Jacobs disease. So this is actually called mad cow. We know it better as mad cow. It's bovine spongiform encephalopathy. So basically, this is a protein that is passed on, or a mutation that's passed on from one host to someone else, and they now contract that disorder and that disease, and it winds up killing them within about 6 months. Most of the time, we're catching it from what? Hence the word bovine. Meat. Infected meat. And usually, unfortunately, here's the reality of the food industry. It's regulated differently in different areas of the world. So if you're going to go to Europe, you might want to go vegan. Just for the trip. You know what I'm saying? Just let's be real. I don't know if I want to contract something like that, out.
Even our meat in the States, it says packaged in the US, so the meat of the meat's from the United States.
Yeah, that's always good, right? I want to bring this uplifting the message to you all today, right?
Buy local.
All right, so we're going to talk a little bit about, well, let me just go back to what we were just talking about there. So each of those disorders is connected in some way to some type of something else, okay? So if I go back to, pages are getting all screwed up, sorry. If I go back to, say, Alzheimer's disease. Alzheimer's can be genetic. It can also be lifestyle, and it can also be a combination of other things. Vascular dementia can be the result of normal aging, or it can be the result of a bunch of different things. So maybe that patient has been an uncontrolled diabetic. Why is that such an important factor? Because uncontrolled diabetes now leads to inflammation, which now leads to the smallest blood vessels in the body that are affected. Okay. Lewy body, patient has the beginning stages of this and isn't being treated. They're not diagnosed with Parkinson's disease. They can't understand why they continue to decrease in their abilities, right? Everything is connected in some form or fashion. So with Lewy body, there's abnormal proteins that form in the neurons, and they are going to continue to be abnormal. One thing that's in common with all of these, most of these dementias, is that whenever you have a cell that dies, and I'm going a little out of context here, but I'm paving the way for what we're going to talk about in a few minutes. Anytime a cell dies, it releases something. And we're going to talk about glutamate. We're going to talk about the progression of dementia as it happens actually in the brain. But each time it's damaged, more is released. More is released, more proteins form, more cells die. It goes on and on and on, just in different ways. There's just different ways that this is happening, but essentially the brain is being deprived of oxygen in some section that's critical for communication. If it's not communicating with that particular part of the brain, then things are going to suffer and your function is going to be impaired. When we're younger, a lot of times we can compensate. As we get older, our brains aren't quite so neuroplastic. There's a term called neuroplasticity that allows for us to be able to deal with some of those traumatic things and reroute. Let me talk a little bit about mad cow real quickly. Actually, before I do that, I'm sorry, I'm all over the place here, but let me get back to basics. Scope of practice warnings for our nursing professionals. So here are some of the medications. Spiridol, Haldol, they can kill the Parkinson's patient with Lewy body. I want you to make note of that, right? If you see that coming across when you're doing your start of care, that shouldn't be there. That should always be questioned, okay? And it's easy to see Risperidol and Haldol being used in populations of people who are out of control behaviorally, yeah? Okay, that's why there's such a, there's a correlation physiologically with these medications. We have to make sure we understand the meds we're giving to people.
Isn't scopolamine another one too?
Scopolamine is actually, it is cholinergic, right? So those patches, and that's for the later stage Alzheimer's patient. We'll talk about that a little bit later. Risk to benefit. Scopolamine is actually going to dry out secretions a lot of times. And we'll talk about that a little bit later, and we'll get a little bit into the weeds with that. But I want to make this applicable to my ADD. So mad cow disease is actually a prion disease. And what that means is that there's little protein fragments that continue to reproduce themselves in really screwed up ways, kind of like cancer almost. But these are protein blocks that help to repair. If they're not producing normal building blocks that are shaped appropriately for the job, what happens to them? They continue to produce misshapen forms of themselves. So here's an example of what happens. If you any of you guys here, guys or women too, have you ever built anything like a house? Where do you start building a house? With the foundation. If the foundation stones are all, what's going to happen to the bigger structure of your house? It's going to collapse in on itself, right? So we want to make sure that we're understanding that the human body is a lot like that. When these proteins are produced, they repair different parts of the cell, and they've got a specific lock and key function. They're like a puzzle piece that fits in. If the puzzle piece fits in, we don't take the X-Acto knife and try to carve up a new one. The body can't do that. It just keeps on reproducing these, and that's what leads to this being such a destructive disease. You should see the segments of brain of a patient or who's died, or an animal that's died from BSE, because it really looks like a sponge because it's got all these holes in it from the destruction that's happened to the brain tissue. So we're going to talk a little bit more about prions and different building blocks as we go into the A&P of this. So let's take a look at the non-reversible dementias. We got 65% of them. A lot of times age is the greatest predictor. Alzheimer's is the most common cause, affecting up to 47% of people over the age of 85. So 47%, if we had all of you were in that age range from like 65 all the way up to 85. If we had all of you in this group, probably about 5 out of 10, 4 out of 10 would be very, very likely to develop, if that's what we're going on percentages and odds, right? And that's striking when you think about it. 47% of people over the age of 85 will develop Alzheimer's. Young onset, 5% of the cases, ages 30 to 60. Again, that's a rare variant, but it does happen. Late onset, 95% of the cases over age of 65. 95% of the cases are over the age of 65. Reversible dementias account for about 25%. We talked about this briefly. Treatable, caused by delirium, metabolic disorder, depression. We talked about the layering effect of dementia. There's other factors that build up and contribute to the overall cognitive ability of the person, or decreased cognitive ability of the person, right? Static dementias, that's about 10%. And the reason we classify these into different categories is the reversible ones, if you take those factors out, you can help the patient to recover to a point. So if you've got somebody who has hypothyroidism, for instance, and their thyroid is way off, they may be depressed, they may have memory loss, they may have some difficulty with emotional control, but they don't have dementia. They just need their thyroid to be balanced out, right? Metabolic disorders are really, really important to diagnose because they're part of that layering effect. We need to treat those as well. That's what docs are looking at, right? Depression. Oh my goodness. Classic symptoms of depression. Do we know what they are? Anybody? Nobody here ever been depressed? For real?
Sadness.
Inhibition.
Sadness.
Sadness.
Lack of inhibition, lack of isolation. I don't want to be around people. I don't like people. That's situational depression sometimes. But with the Alzheimer's patient or the dementia patient, we start to see them withdraw from crowds. They withdraw from situations where they have to be able to remember events and names and talk to people. See what I'm saying? There's a lot of similarities. And depression's treatable, right? Depression is treatable. Metabolic disorder we talked about already. Static dementia is about 10%. Alcoholic dementia, head injury, and stroke. We see CTE comes to mind. You know what CTE is? No. It's concussive traumatic encephalopathy, which basically means a patient who's had multiple head injuries now has destruction of parts of the brain that release something called glutamate. And if you do this enough, that glutamate now sets into motion these little proteins that are generated that start cutting off other sections of the brain and causing the cells to die. That's essentially what's happening. So that CTE is happening with a lot of contact sports. It's happening with people with multiple head injuries, right? We see it accounting for about 10%. Strokes as well. Strokes do the same thing. We talked about that briefly as well. So we're going to talk about Alzheimer's disease. We're going to see a video right now that kind of goes over a real quick of what I just kind of described.
What is Alzheimer's disease? Alzheimer's is a slow, fatal disease of the brain affecting 1 in 10 people over the age of 65. No one is immune. The disease comes on gradually as 2 abnormal protein fragments called plaques and tangles accumulate in the brain and kill brain cells. They start here in the hippocampus, the part of the brain where memories are first formed. Over many years' time, the plaques and tangles slowly destroy the hippocampus, and it becomes harder and harder to form new memories. Simple recollections from a few hours or days ago that the rest of us might take for granted are just not there. After that, more plaques and tangles spread into different regions of the brain, killing cells and compromising function wherever they go. This spreading around is what causes the different stages of Alzheimer's. From the hippocampus, the disease spreads here to the region of the brain where language is processed. When that happens, it gets tougher and tougher to find the right word. Next, the disease creeps toward the front of the brain, where logical thought takes place. Very gradually, a person begins to lose the ability to solve problems, grasp concepts, and make plans. Next, the plaques and tangles invade the part of the brain where emotions are regulated. When this happens, the patient gradually loses control over moods and feelings. After that, the disease moves to where the brain makes sense of things it sees, hears, and smells. In this stage, Alzheimer's wreaks havoc on a person's senses and can spark hallucinations. Eventually, the plaques and tangles erase a person's oldest and most precious memories, which are stored here in the back of the brain. Near the end, the disease compromises a person's balance and coordination. And in the very last stage, it destroys the part of the brain that regulates breathing and the heart. The progression from mild forgetting to death is slow and steady and takes place over an average of 8 to 10 years. It is relentless and, for now, incurable. Helping your family, friends, and neighbors to better understand Alzheimer's will reduce stigma, improve care, and even help the fight for a cure. Thanks for helping to do your part. Learn more at www.aboutalz.org.
Okay. Any comments about the video? So that video really captures kind of where the damage is happening and why, and what is being affected. So it's cause and effect. So when those plaques and tangles begin to build up, and we're going to pull that apart a little bit too. When you hear the word plaques and tangles, I don't know, my brain went to bad hair and teeth. Really, when I first heard the terms. But the terms are really more along the lines of what is being formed in the cell and outside of the cell. So see, the human brain cell is a remarkable piece of machinery, right? It is a rapid communication system. And we're going to talk about how that's set up. But when you start to block off the function of that communication from one cell to the other, you've got literally trillions of cells in the human body as a whole. But we've got an enormous amount of cells right here in dense, compact, highly functioning mechanisms. And when you start to pull apart little pieces of those and you discontinue communication, that's when we start to see what you saw in the video. We start to see the areas of the brain that control our memory. So we didn't talk about the hippocampus too much before, but we are going to talk about it now. The hippocampus is like where memories are stored, right? That's where they're generated. That's where they're stored, right in that part of the brain, short term especially, right? The longer term are going to be stored in the back of the brain, but the hippocampus is storing the short term. Okay. When you start to impair that, now you got 50 First Dates. Did you ever see the movie? The Adam Sandler movie? You guys ever see that with Drew Barrymore? Okay. That she had a traumatic head injury that caused her to forget everything in 24 hours that she had learned in 24 hours. So she literally only had, and that's based on a true story. Believe it or not, it was two remarkable characters, but it was based on a true story related to what we're talking about right now. Memory is vitally important because it gives us a place of reference. Our brain now can work and do the things it needs to do because it's done those things before. Well, now when you cut off that section or you damage that section, the brain doesn't have a reference point. Now, the beautiful part about the human brain is that it'll find other ways to kind of compensate. We see this with traumatic brain injury. We see this with patients who've had strokes. We see this with kids who've had, epilepsy that has caused them to do hemispherectomies on them, where they've taken part of the brain out, and the rest of the brain actually functions very well and is able to reroute and compensate to a certain degree. There's still deficits, but it's able to compensate. For the older individual, as we get older, there's something called neuroplasticity. It gets diminished the older we get. We don't have that ability to recover. And if the damage is too catastrophic, it just doesn't recover, right? So Alzheimer's disease, as that fits into this continuum, is a slow progressive deterioration of the brain. So when we talk about plaques and tangles, we're going to show you a picture of what that looks like. Essentially, the brain cell, the neuron, is being undermined from inside and from outside. So there's damage happening inside the cell. There's damage, which we talk about as tangles. We describe it as tangle. And the plaques are on the outside of the cell. That's where proteins are aggregating on the outside of the cell and blocking communication. It's kind of like if you take a telephone, right? Remember the old landline telephones? And you've got the telephone and you pick it up after it's rang and you talk to the other person on the other side. Somebody comes along with a pair of scissors and cuts the cord that's to the wall. Communication cut off. Are you going to be able to talk to that person again? No, not until you splice that cord up and try to fix it. Brain doesn't do that. It just cuts it off and it no longer talks to that part of the brain anymore. When you do that enough times, over and over and over and over and over again, billions of times, that's where we have Alzheimer's making its progression. And what did they say? How long does it take for it to progress? 8 to 10 years, pretty much. We use 5 to 15 is a wider range where you start seeing the first, you might see the first symptoms. That report that I gave you guys is really kind of taking a look at all of the different pieces of what's going on with Alzheimer's disease and research right now. There are tests that can be done, blood tests that can be done, PET scans that can be performed, different pieces of data that can be pulled in to determine whether or not a person actually has Alzheimer's and get them started on certain medication that's going to help to slow the progression. It's not going to cure the disease, but if it's caught early enough, most of the medications that we see will slow the progression of the disease. And there's a lot of different areas that are being explored right now that I think it's, and I'm going to continue to endorse this because I've been reading through this report, and there's a lot of words in there that are like way longer than I need to have and contemplate. But the theory is still sound, and it fascinates me. There's a lot of really cutting edge stuff that's on the horizon right now in 2025. So that gives us some hope. So up to 2/3 of brain matter is lost by the end of the disease course. So you've got a brain that maybe weighs, I don't know, 5, 6 pounds when it's healthy. By the time the disease has done its work or its destructive work, it's now 2 pounds. So there's a tremendous loss of tissue. We have the early, mid, and late stages. We have ranges from 6 to 15 years, as I said before, not 5 to 15 years, 6 to 15. And then the onset may be years before symptoms show. So that's why these testing protocols are really important, especially if you have a family history. People don't always want to know. But if you have a strong family history, I think they were talking about a family either in Argentina or Venezuela that was a case study. They all carried duplicates of the APOE4 gene. And that is a predisposer to developing Alzheimer's. And they all carried it. And it was hitting them all at 30, 20, 30, 40 years of age. And they've become a case study. That family line, that village, has become a case study for research in Alzheimer's progression and treatment. Just a little sidebar. So this is what the normal neuron looks like in the brain. You've got a very healthy looking cell that has a nucleus, it has an axon, and it has dendrites on the end of the axon and also on the end of the cell body. Those dendrites are the way that cells communicate through connecting points. The space between them is called a synapse. And that synapse is where electricity flows back and forth, just like the telephone, right? It flows back and forth, and chemicals help to make that happen. Does that make sense to everybody? Okay, that's a healthy brain on the left. Those are healthy neurons on the left. On the right, we see what happens when Alzheimer's is attacking the cell from the inside and the outside. We see the little tangles. You see those little squiggly things inside of the cell? Those are tangles. We also have amyloid plaques, which the medications that are being developed now are really geared towards slowing progression of that plaque forming. They're attacking, there's gene therapies that are being developed. There's all kinds of cool stuff that's happening that's hitting different places in that glutamate cycle, which is basically when a cell gets destroyed, it's glutamate is released, and that now allows for all of these plaques that are floating around to get aggregated or to stick to the outside of the cell. Once they build up on the outside of the cell can't communicate anymore and it dies. Then glutamate gets released. It's like it's sick. Think about it. It's a cycle that just doesn't stop. And there's so many different levels of interaction. That's why it's so difficult to treat Alzheimer's, because there's different factors that are happening in different people at different times for different reasons. So how do you come up with a therapy that actually attacks everything all at once? You take a look at all of these pieces and you try to intervene at different levels. Does that make sense to everybody? So that's where the medications are coming from. That's where the treatments are coming from. There's a lot more in there, and I'm not going to get too thick in the woods with that, but I did provide you nurses, hello, with the information that was necessary for the new stuff that's coming out. Some of it's old stuff. Memantine, we've seen that before. The Nezapel, we've seen that before. There's other medications that are on the market now that are really focusing on that amyloid cycle. Okay, so take a look at this. These are called tangles. Now, tangles are those little squiggly things that are developing inside. They're also building blocks for the cell. They repair. They are generated to repair the cells. So the thing about this is that instead of repairing the cell, they begin to produce really screwed up copies of themselves inside of the cell. These tangles now build up. They destroy the cell from within. And the plaques that now build up on the outside of the cell destroy from the outside. Now, one of the things that we need to realize is that a lot of the medications, and again, this is for the nurses, a lot of the medications that we see that would normally we wouldn't have a problem with if we're normal, healthy individuals of a certain age, will be catastrophic for a patient who's in the late stages of Alzheimer's. Acetylcholine is one of those little messenger chemicals that allows for the electrical signal to go from cell to cell. Okay? Acetylcholine is like the espresso in your brain. It allows for movement. It allows for dynamic energy being shared in the cells, right? In the later stages of Alzheimer's disease, patients can lose 92% of their acetylcholine production, which means instead of being wide awake, ding, they're sleeping most of the time. Guess what medications are used a lot in this population, have been for years, and people don't even realize it. Oh, I'm so achy, I gotta have my Tylenol PM. Why is Tylenol PM an issue for the late stage Alzheimer's patient? Anybody know?
PMPs would make them cry.
It's actually in that class of what we call anticholinergics. So an anticholinergic is a medication that actually blocks the production of acetylcholine. So if we're decreasing the amount of acetylcholine in somebody who's already got a decreased amount of acetylcholine because of the disease, they're going to be sleeping they're already sleeping 22 hours out of the day. They're not going to get up. Remember, our goal as caregivers is to help meet the person where they're at in this disease process, and to understand where they're at, and to help to intervene or to avoid certain medications, right? That's a medication that we should try to avoid. So acetylcholine is an incredibly important neurotransmitting chemical, and a lot of the medications that we're going to see are going to be geared towards really helping acetylcholine production. Okay, so whatever's blocking off the acetylcholine production, we have something called acetylcholinesterase, which is going to actually encourage that production, right? Or work on the things that are blocking production. So let's talk about medications real briefly, more so. Okay, you brought up a great one, Ashley. What was it?
Scopolamine.
Scopolamine. So scopolamine, for those of you who are lay people here, scopolamine is simply it's a medication that we find a lot of times in patch form that goes onto the back of the right under here on the neck. And what happens is that's delivered subdermally or transdermally, and the patient absorbs it, and it works on this, on acetylcholine production. Why? Because one of the things that happens when you decrease acetylcholine production is you now decrease the secretions that happen in the human body. Okay. So if we got a patient who's hypersecretory and they got a trach in, or if they're prone to aspiration or whatever the reason is, doc might give a medication that's going to help to decrease that production. So now we see this happening in a trach patient who's got Alzheimer's in the later stages. What do we do? That's why they get paid the big bucks, right, Dr. Smiegel?
I'm sorry, what did you last say? I lost you on the last acetylcholine pathway. Go
I said
ahead.
that was why the docs get the big bucks, is to figure out whether or not that patient's going to get the scopolamine in the later stages of Alzheimer's and what the risk to benefit is at that point.
So I was a primary care doctor. We didn't get big bucks, so.
Oh, dude, that was awesome. Sorry for that, but that was awesome. Well done. So thank you for your honesty, doctor. Appreciate that. That's the fascinating piece of this, and it's really, that's why medicine is called an art, is because you're really kind of looking at everything, and you're finding a way to navigate through that that's going to help the patient have the best outcomes, right? So the scopolamine, probably contraindicated unless there's something else, then they do the risk to benefit. If that makes sense. Okay. Moving on. So everybody's clear on the function of acetylcholine. It's responsible for energy. It's responsible for that awake state that we're in when we get up in the morning and we give ourselves a little jump start with the caffeine, right? So this is what a brain looks like that is healthy. This is a slide section of somebody who is not suffering from Alzheimer's disease. Why do we know that? Because the one on the right is someone who died from Alzheimer's. There's a little organ here that was just discussed, and if you take a look at the graphic that's up, folks, those of you who are online right now, you can see at the 5 o'clock position on the one on the left, 5 o'clock is down like this, right? You see something that kind of looks like a little walnut. That is the hippocampus. So the hippocampus, remember, what did we say that was responsible for? Making short-term memories. It was responsible for that whole generation cycle of memory, right? So now it's robust in the healthy brain. Can you find it in the Alzheimer's brain? It's not even there anymore. And also you can see where that brain has now gone from a 5 to 6 pound organ to 2 pounds. It's tragic when you think about it, because we see physically what's happening, but then there's an emotional component that comes with this, a social component. So the effects on function. So we take a look and we see, what does the brain in the parietal lobes, the frontal lobes, we see the Broca center of the brain that is controlling speech, okay, language cognition. The speech center of the brain is actually that Wernicke, remember Wernicke-Korsakoff? You ever seen anybody who's suffering from Wernicke-Korsakoff? And I've seen a lot of organic brain syndrome patients who are wet brains, right? In my day, I've seen a lot of them, and they have a chronic slur. Their speech is affected because of chronic alcohol abuse. That doesn't mean that that's always going to be the cause, but we see that tying in quite a bit. Okay. Each part of the brain is important for a different function, and it's like a symphony. It works in concert. Each part now complements the other and has checks and balances that allow us to be who we are. Some of us are better at math. Some of us are better at art. Some of us are better at all of them, and we hate all of them. Right? Some of us are better at creative thought, and going into and conceptualizing, right? Some of us need hard facts. Some of us are learners who really hands-on. We love to have things that we can mess around with and play around with, except Epic, and that just drives people crazy, doesn't it? Yes. Different types of learning styles, different methods of communication in the brain for different jobs, okay? Alzheimer's will eventually affect many of these functions as it progresses. So one of the 4A's of Alzheimer's is amnesia. That's loss of recent and remote memory. So remember what I said, 51st dates, right? What happened 2 seconds ago? Where am I? Where's my mom? Where's my husband? I just told you. Where are they? You'll tell them again, and they'll forget again, and you'll tell them again, and it will just continue. Damage to the hippocampus, that processing formative place for memory. Memory is a network involving different areas of the brain, so it's not just the hippocampus. Memories are stored in other parts of the brain, and what happens, it's amazing with habilitation therapy, and we're going to talk about that a lot, is that we can actually access those other pieces of memory in other parts of the brain. Here's a for instance, say, if you close your eyes right now, you guys close your eyes. You guys can close your eyes too. Nobody's driving, right? Okay, you can close your eyes. I want you to smell or think about the smell of something that is a memory. Now, it could be bacon cooking. It could be bread baking. It could be a scent. When you think about that odor or that smell, where does your mind go? Can you taste the bacon cooking? You know what it tastes like? The crunch, the savoriness, the saltiness of it. Can you describe any of those other feelings or those other sensations that are happening? If you can, and if you are, don't go to sleep on me, folks. Come on now. Wake up. Your acetylcholine needs to be up here. If you could figure out where those connecting points were to different memories or times or things that were happening. Like I could drive down the avenue, and I remember 30 years ago, Lydia's on the avenue in Cushing Avenue in New Bedford. Right? Sunday morning, what are you smelling? Red. Fall River. Down on Bay Street. All right. Which smell besides low tide? Smell the bread, right? And that sometimes is attached to a memory. Maybe there's something that you were doing when you had that smell and it made an impression, right? It's a connecting point. Different parts of the brain contain those memories. Well, when we're trying to help patients who have had Alzheimer's progress to the point it has, we want to try and help them connect those pieces of memory that are still there. And we do that. Habilitation therapy actually works on that. And we're going to talk about that a little bit, some more. Aphasia. Aphasia is the inability to understand a spoken word or written word or express oneself verbally. If you listen to what Bruce Willis, some of the experience that his family had or has had, you realize in the video, he's got a cake. I still remember this. This is crazy. He's got a birthday cake, and they bring it up to him, and he goes, "Cat." There's no cat around. But he's trying to say cake. He's trying to connect the dots, and he can't, because that frontotemporal dementia he's suffering from is what has progressed to this point where the words are not connecting with the meaning. And that, as this progresses, gets to be a place where language no longer is understood. What you say to the individual is not registering. It's not. And we've all had those experiences, haven't we? Especially with patients that we've been caring for, where we'll ask them to do a task and they don't know what we're talking about. They just don't know. Simple tasks, right? Simple to us. However, here's the thing about Alzheimer's patients. They still will recognize body language. You can be aphasic, you can have deficits, you can have all that happening. But if I come up to you and I go, boom, approach you from back here, Erica. Is this a good way for me to approach you? No, why? Did I startle you? Would I startle you? Yeah. I wouldn't feel safe after that, would I? But if I come up to you and I say, hey, Steven, what's happening, man? How are you? Hand goes out, even if you forgot why he's doing it. Right? Body language. Did I threaten? Was it threatening what I was just doing with you?
No,
No.
called up my name, got my attention.
So there was, and it was tone too, right? These are the things that we learn as we're caregivers that we can practically apply to our knowledge base about what this disease is and where our patients are in that process, right? So we talk about apraxia. That's motor functions, things that we used to normally do, like tie your shoe. How many of you learned how to tie your shoe with the rabbit in the hole or around the tree or, okay, right? We all did that. Your Alzheimer's patient sometimes doesn't even know how to do that. They don't even know what the shoe's for. But that memory, and it's like eating. Well, let's use eating because I don't want to tie my shoe because I've got Hey Dudes on, so that doesn't work. But let's use eating. So I got a patient. I put the meal right in front of him, and I put a fork down there like that. Patient's family member says, "Oh, they're not hungry. They're not eating a lot. They're not hungry." Well, let's take a look at the problem. You just gave that patient pasta on a white plate, and you put a fork down next to them, and they forgot how to use the fork. So how can we intervene to help that trigger that memory to connect to something back in here that's still there? That action. How do we do that?
Change the color.
Put the fork in the hand, go down, pick up the food, bring it up. You'll find that you do that a couple of times, and I'm not saying this is going to work for everybody, but this is kind of the practice behind the theory. We can access the other parts of memory that are still here by going in and going hand over hand and helping the patient do it. We do the same thing with ADLs, right? Washing the patient up, they forgot how to use the face cloth. We bring it out, we give it to them, we say, okay. Now they go back, and sometimes we'll see them go back in and access that memory again. If they just need a little jump start and a reconnect. Does that make sense?
Yeah.
Okay. Too many steps overwhelm. You ever have a patient that or a person that who's had Alzheimer's disease and you've wanted to get them dressed? And you go to the closet, you open the closet up, and you're like, what do you want to wear? Like asking a 3-year-old, what do you want to wear? You know what they're going to come out looking like? For real, right? That doesn't match. That doesn't match. Well, I want them to express themselves. Okay. Too many choices. Too many choices. No guidance. I can't figure it out. I'm overwhelmed. I'm getting really upset now because I can't figure this out because I know I'm supposed to know this and I can't do it. Now you understand where behaviors are coming from, right? I put too many choices in front of the person. So now I put 2 sets of clothing out and I say, which one would you? They go up and they say, oh, I don't know. Great. Put the other one away. Problem solved. No agitation. No frustration. You got the job accomplished and they're not running around naked. Okay. Agnosia, loss of ability to remember familiar things. Remember, this is along the same lines as what we're talking about. Forks should be a familiar thing, right? Tying your shoes should be a familiar thing. Picking up your clothes should be a familiar thing until it isn't. We demonstrate, we give instructions, And the less verbal instruction we give, the better. Why? Too much input, too much to process, too much to figure out. Kind of like my presentation right now, right? Okay. So the stages of Alzheimer's disease, we've got the three main stages are early stage, which is average 2 to 5 years. We've got the middle stages, which is an average length of 2 to 5 years, and the late stages, which is an average of 2 to 5 years. So we've got blocks of time that we're seeing the regression or the progression of the disease. So in early stages, we might see short-term memory loss. We might see mood and personality changes, loss of initiative, depression, apathy. We might see isolation. Sounds an awful lot like depression, right? Because that happens when you're overwhelmed and you're thinking about bills and you're thinking about family dynamics and you're thinking about the job and you're thinking about trying to get up and dress yourself in the morning and you're thinking about that stupid line at Dunkin' Donuts. And I've got 5 minutes to be in work. Y'all smiling, you all know, right? Again, we could really mistake this for something pretty normal. Inability to learn new things. You pick up a book, you read the book, you think you know what's up, you ask the questions about what was in the book. I don't have a clue. I didn't learn anything. Sitting in end service like this. Here we go. Sitting in end service like this. If I were to ask you about acetylcholine, do you remember what that was about? Energy in the brain, right? Neurotransmitter. Okay. What about medications that can hurt a patient with Lewy body? Antipsychotics, right? Can kill the Lewy body patient. Risperidol, Haldol. See? Not so bad. We're working it. And I'm just throwing it out there because it's an example of learning. Sometimes, or when we see this in the early stages, that wouldn't be possible. We'd make up a story, or we'd make up an excuse, or we'd excuse ourselves at that moment. Word finding, difficulty, confusion, disorientation, confabulation is the story. I took all this stuff and it sounded really good, but I don't have a clue. I fake it to make it, baby. That's what I do. Visual spatial disturbances. I can't. This is tough because I wear progressives, okay? Anybody here ever wear progressives? How weird was that trying to get used to that?
It didn't bother me at all, I'm sorry.
It didn't bother you? Oh my goodness. I stepped out of the doc's office with my new glasses the first time and I go like this because I'm looking down and I'm not looking through the right place. My brain hadn't quite figured that out yet. And I'm like, dude, this isn't cool. There was no step there. What am I doing? Right? Very simple spatial disturbances. Diminished sense of smell. All right, so as we get older, we lose those abilities, right? Sometimes we don't. Sometimes we have olfactory fatigue. Can any of my nurses and aides represent? Olfactory fatigue. That simply means that you've been bombarded with scents that were so strong and so powerful, and you've worked in them so long that you've just kind of blanked out the fact that they're gross. Yeah. Diminished sense of smell, trouble performing tasks or abstract thinking. I can't think down the line to plan. Remember kids in the developmental cycles? Sometimes abstract thought in the teenager is very difficult, isn't it? That's why they are risk takers. That's why they don't see the possible consequence to the action. Does that make sense to everybody? We see this in the early stages of Alzheimer's disease. Middle stage, 2 to 5 years. Functional losses in fine and gross motor skills, loss of long-term memory, loss of language abilities. Again, here comes that aphasia. Visual spatial disturbances get worse. They're not able to function. And it scares them. So guess what? They don't. They don't. Appetite changes. As we get older, sometimes Our appetites change. Our taste buds change. Our ability to process taste, although I've had some funky tasting stuff, man. And I had to say, yeah, that tasted really good. Anybody ever have that happen? Especially when your spouse cooks it. Gotta make sure, hey, this was good. It was good. It was really good. I promise you it was good. I'm not encouraging lying, by the way. I'm really not. Appetite changes, incontinence. Where you were not incontinent before, now, whoops, there it is. That's not normal. This doesn't happen. This had never happened before. This is the mid stages. Wandering, forgot where I was going. How many times have we heard about people going out, walking out of their house and not knowing where they are and being found somewhere else by the police, wandering around, not having a clue, or worse yet, wandering out, dying because of the elements, lost like 1,500 feet from their house because they got lost. This happens. Psychiatric changes, paranoia, delusions, hallucinations, anxiety, and aggression. All of these are really, they become compounded, and they are all connected to the degradation of the brain. Late stages, we see dependent for all ADLs. Your patients, honestly, a lot of them, if they're in the late stages of Alzheimer's, they're probably sleeping how long?
Most of the day.
Probably 22 out of 24 hours a day. They get up long enough for you to get them up, maybe eat something or drink something, and then that's a challenge in itself because they forgot how to eat, they forgot how to swallow, they forgot how to do pretty much everything, and then they go back to sleep. Little, if any, speech at all, not communicating, not able to communicate, possible seizure activity. So because the brain is having destruction happen in so many different places, you now start to see more and more seizure activity as a result. Withdrawal, death often due to complications from illness. So we see death resulting a lot of times from aspiration. Patient has aspiration pneumonia because they forgot how to swallow, because they pocketed their food, because they got put down in the bed. They aspirated. 48 to 72 hours later, you got a patient who's now spiking temps, and you have no idea why. They probably aspirated. The junkie, the sats start dropping, and with that patient, they have next to no resilience when it comes to their immune response. Sensory changes. All senses can be affected. Sensory organs still function, but the brain cannot make sense out of the information. This can cause fear. I get scared. I don't know about you, but if something doesn't feel quite right, have you ever woken up from a dream and you're trying to determine if it's reality or if it's the dream still? It's disorienting, isn't it? And it's scary. You wake up, your heart's going like that. Picture being like that at that level every day. In some form or fashion every day. That's what the Alzheimer's patient is going through. Age-related changes can compound the effects. Smell, we already talked about this. You start seeing patients they start putting a lot more sugar, a lot more salt on their food, and they don't stop. They might put mounds of it. That's sometimes a warning sign, right? As we get older, we lose that ability, but not to this extent. Vision becomes impaired. You'll see in a lot of the Alzheimer's care centers or care floors, they will set the room, they'll set the hallway up with the places of egress. They'll put a dark carpet across the front of the door. You know why? Because the patient who has Alzheimer's disease, a lot of times their spatial ability, they see a hole. They don't recognize that it's just a dark colored thing. They see a hole, and they will avoid that falling into the hole. Okay. Reduced field of vision. So here, remember I came up to Stephen and Erica? So if I come up here and I want to have a conversation, your vision is out here, about the size of a basketball for the patient who's suffering from Alzheimer's, right? So that's their spatial awareness. I can see out here when I go like this. My peripheral vision allows me to see my fingers twiddling out here. That's my peripheral vision. It's just about this size. So everything that's outside of that area now becomes a threat. Okay. Contrast. Let's go back to the plate. Remember the plate? White plate, mashed potatoes. Does that work? I can't see the mashed potatoes. No wonder they're not eating. So what's the next step that we do?
Change the color of the light.
We change the color of the background. Contrast, right? Absolutely. So if I see that coming at me, first of all, shouldn't have done the shrooms, right? Poor person sees their child coming at them and they don't even recognize the child because that's the fragmented vision that they got. I understand why there's so much fear and anxiety associated with this disease, right? There's the copy of the white plate and the mashed tater. The only thing that's I'm mildly aware of that if I was to look at that quickly, like through the shaded version, is the butter, and I can't even see the butter. It's a slightly different color. That's a much more contrasting background that allows me to see that and say, okay, so I may have lost all of my ability to recognize things, but that right there, I can see the spaghetti now. At least I can see it. So that if you come over here and help me eat, at least I know that there's food on the plate and I kind of access that piece of memory that says I need to eat. We see touch being affected. Nerve conduction is decreased. So guess what? Grandma goes and puts something on the stove. Gets it on the stove. Sees it starting to smoke. Goes over to the stove, grabs the handle. Doesn't really feel it at first, but drops it quick, right? The initial feeling that signal was delayed. How about getting into the bathtub and the water's too hot? Didn't feel it until it started doing the damage, right? Those are just examples. Difficulty feeling pressure, vibration of pain, and compassionate touch, though. That's the thing. You can get all of this diminished response in your nerve endings and your processing. But when somebody comes up to you in front of you with a kind voice, and it's not appearing to be a threat, compassionate touch has a way, that's the body language that now, a lot of times it's very primal. It goes back to who we were when we were kids, right? When we were children, we were babies. We looked for that touch. We snuggled, we cuddled, we were rocked to sleep. Those are almost the last memories that go as we regress back. We do that Benjamin Button type thing, right? So hearing is another challenge, right? We're going to come back to this. I want to send you guys to break, take 10. And then we're going to come back because I really want to finish the presentation and I want to give us at least 15 minutes to debrief and to ask questions. So we still got plenty of time, but I'm going to give you guys 10 minutes to get up and stretch. You guys that are there, go feed Ziggy. Make sure Ziggy gets a treat, Kelly. We'll come back to this in a few minutes. Stops. Seriously, it's like, let's get started.
So you're talking, I'm like, this is not you.
So I'll be trained in natural remedies and therapeutic massage and hydrotherapy.
I'll have to take the course with you after.
Well, there's a place called Light Ministries that came and actually put on the presentation for us. But we did the initial course was about it was 5 days long. So we had 2 full days and 4 2-hour sessions.
Conference.
It was great. No, it was at our church. We had about 20.
That's
24
awesome.
people
5
showed
days,
up.
that's like a big old, like a conference.
Yeah, it was
Big
interesting,
Convention.
and we had good turnout, which was amazing to me. It was cool, and one of the things we did was massage,
Yeah.
like not like, oh, I'm going to school for this,
Right.
but just real therapeutic
basics,
stuff,
yeah.
right? Just kind
Because
of
you get
basic.
some injuries if you don't know what you're doing.
Well, again, here's nursing me like I'm a PIA. Because the people who are doing this, one is a social worker and the other guy was a natural foods manager, natural food stores. I made it very clear. I said, you've got nursing professionals in the house. We're going to talk about the things that you can't do. Yeah.
Right.
Yeah. She was really good about that.
Oh, that's good.
Like know the person that you get permission from the person.
Right.
Know the person. If they have blood clots, if they
Right,
have
right.
anything else like that.
Background, yeah.
If they're on blood thinners, stuff like that, you probably want to avoid things like that.
Right,
So I really appreciated her attention.
Oh, that's
that.
good.
That's nice.
So yeah,
So you got a whole,
it was fun. It was fun. We got the cooking demo was a lot of fun. I bought both of her books. Plant-based.
Oh, nice.
Didn't have a lot of the macros in it that I would have liked. But I can figure the macros out. They give the servings for each of the recipes.
that goes into what Mediterranean thing that you talked about. You the one that talked about Mediterranean diet and all that.
Well,
background?
for this,
I think the last time when we talked about, when I was.
similar,
Yeah,
yeah.
you kind of touched on it.
It was more
Yeah.
more not really keto, but modified Mediterranean. And this was more along the lines of vegan. So she was doing vegan cooking demo.
Yeah, with the plant-based.
Yeah. This is what's fascinating about this report, because as I'm reading through here, just verifying what we already know,
Yeah.
lifestyle.
There's one thing when you mentioned that I was thinking about, I've been hearing a lot in research showing strong legs equals less risk of Alzheimer's and dementia. And they're talking about working out your legs and muscle training.
Yep.
And strengthening the muscles of your legs because you have your bigger muscles. There's a correlation of that, especially for women.
Yep.
Decrease of risk of Alzheimer's and dementia. So mom was like, stop. Get
Do
to
some leg
walking.
training.
Well, seriously, yeah. So this is page 9 of this report. It says this: multiple lines of research find that several forms of non-pharmacological interventions may also offer promise in reducing dementia risk factors and improving cognition and memory. Results from randomized controlled trials indicate that interventions with blood pressure control, hearing aids, multivitamins, and personalized health coaching can reduce dementia risk in specific populations, but more research is needed. So they go on to expound on some of the methods that are used. But here's this is what fascinated me. The modified Mediterranean ketogenic diet. So that's the MMKD, right? This is what it says. Composed of 5 to 10% carbohydrates. That's what I eat, 5 to 10% of
Fats.
right? 60 to 65% fats, which on healthy fats, probably not that high. I do my avocado and my olives. That's my healthy fat. And trying to get rid of cheese, but cheese and I have
I love cheese.
we have a love-hate
But the olive
relationship.
oil makes sense because there's a lot of research now on the whole olive oil shots in the morning and all that stuff that we're doing. It would make sense in line with that. Even butter,
Yep.
although that wouldn't fit into the plant-based. I've been seeing a lot of things about butter and the benefit of that
Yeah.
for your brain,
Mhm.
Absolutely.
like the real butter, not the fake
And
butter.
making your own butter is really, yeah.
30% protein for 6 weeks had significant changes in both blood and spinal fluid biomarkers associated with Alzheimer's risk. So diet has a tremendous impact on those who are at risk. And when I was reading through this, they were talking about the APOE2 gene, which is a predictor of Alzheimer's, and the APOE APOE4, which if you have that with the APOE2, that almost guarantees that you're going to develop Alzheimer's at some point. So the gene therapies, the genetic research connection is really fascinating when it comes to lifestyle.
Yeah. What about, is there anything there about cholesterol? Remember we were talking about that,
Yes.
like how like an
Yeah.
anti-cholesterol medication increases
Yes,
risk for Alzheimer's,
yes,
because your brain
yes.
needs cholesterol to like,
So your
What-
cells, absolutely, your cells need cholesterol to rebuild cell walls, right? The problem is that in the American diet, we have so much overload of the things that are not healthy for us.
Right.
When it comes to, there's no balance to it at all. So you've got high carbohydrates, high fats, high saturated fats, high cholesterol, in the sense that you now, instead of what your body needs, you're now overloading your liver's ability to function, because it's a meat producer of cholesterol. So I find it fascinating when we talk about these things, because it's easy to relay the information, but when people are really hardwired here
Yeah.
to be unhealthy and it's connected to culture,
sure is.
it's very difficult to have the conversation and have the walls not go up. And it's sad, because you get to that point where the disease has already taken its course. And that's what we see. We see the end results. I'm so done with that. Like, all right. Everybody have a nice, get up and get your blood pump into the lower regions of your anatomy. That's good. You need to have no pressure stores. Okay. You have everybody back?
I don't know, we're missing. Oh, missing two. DNA and the volunteers. Now we're just missing.
You want to read some good studies at the Mass General
No.
neurologist.
No.
He does all good studies and all this stuff.
Then now he works at Mass General as a specialty in neurology or gerontology.
Neurology
Neurology,
in all the dementias and different types of dementias and different kinds of neurological issues and stuff like that.
I think when you look at what we're doing today, that's why I gave the additional information and I attached it. That additional information on medications that are being utilized are hitting this from about 3 different places. And I took notes down on this. Gene therapies are one of the interventions that's being used for patients identifying genes that predispose to Alzheimer's, and also utilizing gene therapies to try and reduce the risk. So the anti-amyloid and immunotherapies, those are geared towards that glutamate cycle that we were talking about, where glutamate is released when the cell dies. So glutamate is released. It forms there's a sticky substance that forms on the outside of the cell, that now these little fragmented proteins come and they connect to that. They build up on the outside of the cell. The cell can't communicate and the cell dies. It can't bring sustenance in, and it can't get rid of the waste. So now the cell dies from the outside. That happens each time a cell dies, that cycle gets kicked into gear. So stopping that from happening is really kind of the approach that a lot of the medications that are being developed.
Well, it's very interesting. What I did hear from you is like the chemotherapies and things like that. I had a loved one that developed CAA, cerebral amyloid angiopathy.
Yeah.
And the only way they know that somebody has that is to actually take a brain biopsy. And so, we were around here down the Cape and nobody knew what it was. And it took months, and they thought, he was bitten by a mosquito and all kinds of different things. And then finally I just said, we got to go to Boston. And that's what he ended up having. But what was interesting is, like you said, they gave him for a year, I don't even know the names of the medication, but some very strong chemotherapy where they had to dress up in suits and I had to dress up in suits. So I think to myself, what's going to be the future? It helped him tremendously. He's doing wonderful now, but I think that kind of, how is that going to affect?
Again, I will refer you to that report because it outlines all of those methods that are being explored. And
Right.
one of them is it's an IV delivery of medication. I forget
Right.
now what the exact medication is, but I've got a whole list of them here. If you want to take a look at some of the medications that are being utilized, but some of them are infusions.
Yeah.
A lot of them are being utilized to interrupt that cycle.
Yeah.
So the amyloid gets
He's
interrupted.
being followed by Dr. Greenberg and by Brigham. So he's being followed by both Mass General, and he's in a study. So
Oh, you got the big guns
he's got,
out, right?
yeah, I just put my foot down and said, and plus they want to study him because not many people have CAA. So it was just fascinating.
It is.
Fascinating.
It's hard though.
It's
because
terrible.
It's somebody
It's
that you love,
awful.
right?
Yeah, it's terrible, but it's fascinating to, like, I didn't even think of that aspect. That's new to me.
So that's good. That means you learn.
Yeah.
I'm actually conveying learning here. That's amazing. I love that.
Yeah.
I want to inspire you guys to really connect because it gets really overwhelming from the clinician standpoint. We're constantly like on the go 100% all the time. And it's very hard to take time out like we're doing right now to kind of connect. The same thing goes for volunteers. Volunteers, you guys are going into the patient's homes. You are giving respite care and knowing where these patients are and what's happening is really important because you can start realizing what the patient's family members are going through. What some of the challenges you personally have experienced something similar to what a patient's family member is going through, right?
Right. Well, my philosophy is I don't care how much education you have. There's not a day that you can't learn something.
That's right. That's right. That's such a good attitude. I love that. I love that. All right, let's get started back again. So we left off with talking a little bit about how the senses are affected. Hearing is the last sense that is affected. Those of us who attended a lot of concerts, well, you know what? We kind of expedited that a bit. But as we get older, you know, it's interesting. If you think about what's happening in the ear to make sound happen, there's nerve conduction in the auditory nerve, and there's also these little itty bitty bones inside of your ear that now slap up against and cause vibration when you hear sound. That sound is interpreted through the nerve pathways of the auditory nerve into the brain, and then it's all sorted out, right? Well, as we get older, those little mechanisms in our ears become stiff. They don't work as well. They don't convey sound as well. And that's where we have, and that, to be honest, that tympanic membrane, our eardrums, they get really kind of stiff too. If they get stiff, they don't convey sound as easily, right? And even if they did, somebody who's suffering from Alzheimer's disease, that part of the brain is now diminished in its ability to sort out the sounds, right? So it can sound like a whole mess of overwhelming noise, right? 50% of people over the age of 85 have hearing loss of ability to hear frequencies in the upper ranges. A lot of folks don't understand they have the most beautiful caregivers, but they're up talkers. And they have this high pitched, oh, honey, how are you? And to come into somebody who's suffering from this disease, depending on if they're in the later stages of the disease, they're not hearing them. But if you're bringing it down a notch and you're keeping it down in a lower register, they're able to understand that better. So the lower tones, as opposed to the higher pitched tone, and we see that higher pitched tones happening when we get what?
Excited.
Right, or we get stressed, right? Okay. So diets, we already know about diets. I'm not gonna beat this too much because I do want to get us into talking about some of the practical application of habilitation therapy and some of the things fascinating that we've got in the rest of the presentation. Food consistencies, we already know that as this disease progresses, depending on other factors that may be overlapping here, like stroke or traumatic brain injury or decreased ability or function, right? You now have consistencies of food that have to match what the patient's ability is. So regular food would be like a steak and potatoes. They can cut it up, they can eat it, they can swallow it, everything's good. But as the disease progresses, we now have them going down to a ground consistency. They can't chew up the stuff that they've gotten, that they're eating. They can't chew it up. And they may have some difficulty swallowing as well. Then we have pureed, which now is a consistency of like kind of soup, basically, right? Not even mashed potato, it's just soupy potatoes, right? And then our liquid consistencies, we have to be cognizant. They forgot how to swallow, forgot how to chew. All of those diminished capacity to really perform really basic functions, we see it starting to diminish, and the consistencies have to match that regression so that the patient stays safe and still stay relatively hydrated and have good nutrition. So again, choices. If we're given too many choices, so taking them to Old Country Buffet when it used to be a thing. Now you go down south, it's called Mama June's. Mama June's is like Old Country Buffet on steroids. Everything, everywhere, and people be bellying up. But there's so many choices, man. So many choices. Even for somebody who's not having issues. It's like, well, how do I figure this out? What do I want? When we're taking care of patients, the dietary consideration should take into account that we're going to keep it simple, right? Again, we talked about not being able to chew, forgetting how to swallow. We talked about fatigue and sleepiness for its later stages. Remember, 90 to 92% of the acetylcholine production has dropped off. That's a dramatic drop off. Need for assistance and habilitation therapy, and this is what we're segueing into a little bit. We've been touching on it briefly throughout the presentation, but this is really this is the answer to helplessness from the caregiver standpoint. This is the answer to quality of life for the patient who's suffering from Alzheimer's disease and trying to just maintain what their quality is right now, right? Loss of smell, taste, and vision, and loss of nutrient absorption. And remember, we talked about this too. You got your chemo patients. How many of us in supportive care have dealt with chemo patients and patients who are actively having chemo and radiation in palliative care, right? So there is some of the effects that you're going to see with the dementias are going to either be accentuated or they can be mimicked by the fact that this patient is depleted. They've gone through chemo, radiation, they're having absorption issues. Maybe they got IBS. IBS is an absorption issue as well, right? It's autoimmune, but it's still an absorption issue too. Behaviors are communication. If I can't tell you I need to go to the bathroom, you ever seen patients who need to go to the bathroom and they get wicked agitated and you know they got to go to the bathroom? You get to know people after you take care of them long enough, right? You get to know the nuances of them, what their actions are. If I can't go to the bathroom when I need to, try driving down 195 and you got to go to the bathroom. All right, and you can't find a place to pull off. COVID, hello. I found every single porta potty between here and Cabo. And every bush and tree I could find. I'm not trying to be crass, but hey, listen, you go when you got to go. That's an anxiety. It builds anxiety in you. You feel like out of control, man. And it's she's laughing, you know, because you felt it before, haven't you? I love it when I can relate to the audience. It's great. But these are things that they can't express in other ways other than striking out or being agitated or being angry or being loud, or just being scared, right? Maybe it's too hot or cold in the room. I was just saying, it's moopy in here, right? Too hot or cold. I don't want to go into a house. I went into my mother-in-law's house like last week, actually. She had a UTI, couldn't walk. My brother-in-law thought she had a stroke. I come out 12 o'clock at night. I'm like, she didn't have a stroke. She's still talking to me and she can get her hands up and go, hey. So we were good. Neurochecks were fine. She was just in her room, was literally 95 degrees. She had 3 blankets on her.
Oh my God.
I touched the woman and she was like clammy, hot, like the whole nine. She had a UTI. Had a UTI. But the sense of temperature regulation wasn't there. Why? Because the brain controls temperature regulation. Hello. I'm already, I don't want to say hot flashes, but that'll strike too close to home. So I'll just say we can't have that happen, and it's uncomfortable, right? Okay. So when our environment isn't regulated and we can't control that, sometimes we act out. Communication is frustrating because it's too complex. We can't express ourselves. Task, too many choices, too many steps. We already talked about that. Here's the nonverbal cues. And these are the soft skills. I wear my emotions on my face. How many of you do that? Like when you walk into a room, anybody have an RBF here? You know what an RBF is? I won't say it because I don't cuss. But RBF, it's simply put, you look angry all the time and don't dare come near me or else. And you don't know it. You don't know it because those emotions are showing on your face without you even wanting it to, right? Smiling is the universal sign things are okay. No matter how depleted you are, when you smile towards somebody, a lot of times they will smile back at you no matter how much is gone. And that will set them at ease because that's a memory that's in a lot of different places in the brain. Patient may assume that you're friendly. We do not ever want to go up to somebody and touch them without their permission. Why? Especially this population. Why do we not touch people in this population without their permission? Right. Right. Okay, I'm going to use a real world application for this. You're giving a patient a shower or you're taking them to the toilet and you have to come up underneath them and you have to secure them. Could that be perceived as threat? Absolutely, it could. And if they've seen that happening, they're going to fight you. And they're going to be kicked. They're already stiff, but those stiff little legs, man, they be coming out and smacking you and kicking you in the shins and everything else. It's all in the approach. And sometimes even the approach doesn't work, right? But we do the best we can. Remember, limited field of vision. Again, if I've got everything is closed off to me except for what I've got right in front of me, then all of my actions of care need to be right in front of the patient. I need to be facing them when I'm having a conversation with them. I can't sit off to the side, although here's what happens a lot of times. And you guys can, volunteers who are on here, please let me know what's going on with you. When you're sitting with a patient, do you just sit on the side of them? If it was an Alzheimer's patient, let's just say that it's an Alzheimer's patient. Are you sitting just at the side on the side of them? Or are you actually turning your chair to have that field of vision towards them?
I haven't volunteered yet, but I've been a counselor, but I would face them.
Right. And I think we get in, because I've seen this a lot in healthcare in the years that I've been a nurse. And a lot of times you'll have a sitter who will come in and they'll have a patient who has dementia and they'll sit to the side. And instead of seeing the patient seeing them, they're startled by the fact that person is even there. Whereas if you just turn the orientation of the chair a little bit so you could face the patient, that would decrease a lot of their anxiety, believe it or not. You know, so the just little things that I'm curious about that from the not just the clinician standpoint, but also from the volunteer standpoint. if that's something that we're experiencing with this population. Don't talk over somebody. And here's another thing, folks. When you're talking to a patient or talking to a caregiver about a patient, don't talk about them like they're not there, even if they don't necessarily perceive it. Because every once in a while, they'll surprise you. Say, I'm right over here. Right? Verbal communication tips. Keep questions simple. Yes or no answers. Allow enough time for response. It's delayed. Don't be in a hurry. You don't listen. You're not off to the races. I know it's tough, and as caregivers, it's difficult because we've got X, Y, and Z we got to see during the day, and we've got a certain amount of time we can spend with each person. Right? Anybody feel that? How about online there? You feel that? Okay. So you know that your time frame your time management has to be in place in a way that's going to honor them and give them time to respond. But you also have to be reasonable and say, okay, there's certain things I need to accomplish while I'm here, and I'm going to do it in the best way I can, right? Don't argue or disagree or correct. How many caregivers do you see try to win a fight with the patient verbally? And it escalates. It goes from 0 to 60, like boop, right up here. How do you de-escalate that? How do you help them kind of work through that as a caregiver coming from the outside? Or do you?
Talking about how help the caregiver or help the patient?
You're doing both.
Oh.
You're doing both. So my question is, how do you intervene when you see that escalation point because there's an argument that's happening?
You change the subject.
Maybe change the subject. Maybe matter of fact it.
Go along with the patient. If the sky's red for them, the sky's red. I'm not gonna argue.
Hey, listen. Seriously, right? There's that caregiver stress meets personality conflict that has existed for decades. And now this is the perfect time for us to go at it, MMA style, without doing it physically, just verbally, right? We do this. That's why sometimes it's better to ask that caregiver, hey, I would love to be able to have a conversation and kind of talk with your mom. Why don't you go over there and take care of business? Like you said, you had to go out and do some errands. Go ahead. You'll be back soon. There's somebody back there, right? Okay. You're assuring safety, but you're diffusing the situation and giving them a way to get out of that situation, right? Because we're human beings. We're not robots. We're not. You can't program us, or you can actually. So repetitive questions can be answered again, but distraction may be more effective. I remember in the facilities that I worked at, if you worked 11 to 7, you had your audience of Jerry chairs surrounding the nurses station, right? And what would we do with the ones who were repetitive and were anxious and everything else? Go get the laundry. Go get the laundry, folding towels. And they'd sit there and they'd be like this. And that's all they'd do. And you were like, cool. You don't have to do it perfect. And I'm not going to show you how to do it perfect, but you're doing something. And it's taking you out of that cycle, right? What doesn't work? Criticizing the patient doesn't work. Demeaning them doesn't work. In fact, when you start to hear that happening, those are red flags. For real. Those are red flags. Responding negatively to insults, trying to change their mind, too many choices, raising the level of your voice. I've walked into what storms like that before when I go to take care of people. And you know that the dynamics in there, it's thick. You walk out, you walk in, you do your thing, and you have a conversation. And so come to find out that person's been up for 24 hours straight, trying to take care of this patient who's not sleeping, by the way, whose sleep schedule is all flipped over. They sleep during the day and they're what? All night, wandering, going to the refrigerator, going into the bathrooms, knocking on the door, turn the TV up to all. After a while, the caregiver's like, you're short-tempered and you're ready to blow. Now, I'm not just talking about for us, because we can control, we're not there for more than an hour, right? For the most part, we're not there for more than an hour. They're there 24/7. Give them the out. Repetition for this population does work. But it also can be a sign that they're in distress. Mama, 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 mama. And it gets more intense, right? Here's where we talk about sympathy versus empathy. And we'll breeze through this because there's some really cool videos in here I want to get to. So I feel bad for you. My emotions may cloud my problem-solving abilities. So is it easy if you take care of a patient for an extended period of time, does it become easy to become too familiar? Who does that benefit? That's where we come in as caregivers. We can still love and be compassionate, but we're empathetic. And we got to teach caregivers, hopefully, how to be empathetic in the midst of the chaos that they're going through too. Because empathy is objectivity. You still care, but you know that there's a purpose for you being there. You're there to help that patient. And if you get too sucked into that emotion that's going on, what happens to you? What happens to the patient? Are they going to get what they need? No, you're going to get what you need, right? You're going to get what you need because it becomes about you and it stops being about the patient. When sympathy comes in, it starts to be about us. Inevitably. And that's hard to hear sometimes, right? But it's a reality. So empathetic communication, when we talk about being empathetic with patients and with caregivers too, but specifically with patients, 10% of our communication is in words. Remember, the words are not being picked up the way they're supposed to, and they're not understood. The aphasia is kicking in. So guess what? That's only 10%. 30% is sound and pitch. So now we keep a nice even tone. We keep the tone low. We don't go too high. We keep it soft and calm. 60% is body language, how I approach it. If I've got to transfer them, I do it in as supportive a way as I can. But I've seen what happens in the facilities, right? We know how that works. You got to get 7 people up or 8 people up and get the showers done by this time so we can get the breakfast. Anybody ever have that happen? You have time to do this? You should. But sometimes, same thing happens with caregivers. Caregivers get into that routine and they wind up not thinking about the patient, but thinking about the routine, right? Dementia patients listen with their eyes as well as their ears. You should also listen with your eyes. So triggers for behaviors. We already know what these triggers are, right? Patients who have pain that they can't express will express it in other ways, okay? If I go to the bathroom and it burns when I pee, I'm gonna be a little cranked out. I don't know about you. And I'm gonna squirm and I'm gonna squiggle, right? How about medication? Sometimes patients easier to deal with after they've been medicated or right before they're ready to be medicated. When is the easier time to deal with them? After the medication, right? For sure. Fatigue, sleep problems, dehydration, malnutrition, dental hygiene. How many of you have ever dealt with a patient with teeth and you couldn't understand why they were such a crankpot all the time? You have a toothache? I had one that lasted 3 weeks. Let me tell you what, that was annoying. I wanted to chomp on everybody, literally. Like it was so painful, and it was just like there in the background. It was always background noise. It's like they can't express how that feels. Constipation. Oh. Okay. You ever feel some kind of way from eating too much cheese? Too much cheese, too much McDonald's, too much fast food. Also, sometimes it has the other effect. Remember, circulation, nerve response is not just limited to one aspect of the human body who has Alzheimer's. It affects everything, including digestion. Peristaltic action in the intestinal tract and in the GI system doesn't push things through as robustly as it used to. Now you put on top of that all the medications that now bind up the patient, and they're not eating right, and they're dehydrated. This population gets constipated a lot, and that's not comfortable. Not comfortable at all. And it can trigger behaviors. We talked about these already to an extent. So understanding the experience, this is someone who Dawn has had a lot of experience with in her lecturing on the subject. And his name is Greg O'Brien. He was a journalist. And he had been diagnosed with Alzheimer's, early onset Alzheimer's. And he chronicles his experience in this book on Pluto. If you get a chance to check it out, I haven't done it yet, but I am going to download this onto my Audible so I can at least listen to it, because I have hardly any time to read it anymore, it seems. But he relays a situation where he was on a lecture circuit and he was giving his perspective on his disease. And they had meticulously planned out this trip to Switzerland. And they flew in, and I don't know if it was CERN or whatever the cities in Switzerland are. Capital city, Bern. I think Bern is the capital. I could be wrong. But they flew in, and he was fine until he got to the gate. Get off the gate. Anybody board a plane? What do you run into? Especially in an airport like, say, Chicago or Atlanta. It's crazy. All these people, all the noise, all the input, all the lights, everything. For him, he went primal. And he fight or flight, gone. Before they could catch him, he was already on a bus and going somewhere just to get away. And he relays the situation. They did not find him until 3 buses later, somewhere clear down the center of town. But the point is that to process that information, all of that input was overwhelming, even for someone who had meticulously planned out their response. And I think that's something that when we start realizing that anyone who becomes overwhelmed can go into this, but it's more, the person who is suffering from this disease is more prone to those situations happening. And we got to try to anticipate. Even anticipating, they couldn't anticipate. He just went completely primal. All the input, he couldn't process it. And that's where we find a lot of our patients. A lot of our patients, they have mirrors in their houses or no. You ever go to Alzheimer's units? You won't see mirrors anywhere. You know why? And if you do see them, they try to avoid them as much as possible. Why? They don't recognize themselves. They look in that mirror, they see a stranger. Or they see a younger version of themselves. Right? And sometimes that's troubling, because then they look at themselves and they look in there and they look at themselves and something ain't right. Responding to challenges. So we recognize that it's a disease and not the person causing the challenge. That's the bottom line. We recognize that it's a disease. Are we treating the disease or are we treating the person? Well, we're probably treating both. But inevitably, the person is going to trump the disease. Does that make sense? Don't take aggression or insults personally, and it's okay to take time out. I inspire people, encourage people. If you're a caregiver and you're stressed out, I used to teach teen dads how to take care of their kids and not beat them up. Okay? I worked in a prison, taught them how to take care of the children. I worked in the high schools. Okay. And here's the one thing I used to always tell them, and I just told my great nephew this the other day. He's not really a great nephew, but he's the father of my great aunt, niece. I get it all confused. When we get into the grades, I'm all done. I said, when that kid starts screaming and starts freaking out, and you're getting stressed up to here and you can't control what that kid is doing, you put her down in the bassinet and you walk away. Kid can scream bloody murder, you don't care. You kept from hurting that child. And you got control over yourself and your emotions. Because as sure as I'm saying this to you now, there are caregivers out there who are going to go and they're going to wind up hurting the people that they're taking care of if they don't use these strategies wisely. Right. And if we don't bring these strategies to them to coach them through it, to help them understand, sometimes you can't. But that's that relationship that we build with our patients, right? And with their families. So I want you to see this. This is a really good video. And it kind of highlights a guy whose mom is suffering.
More than 5 million Americans live with Alzheimer's disease. It's a long, hard road, not just for those who suffer from the disease, but also for the caregivers, children tasked with caring for an increasingly dependent parent. 4 years ago, ABC had the chance to put cameras inside a Texas home as a couple took on this terrible challenge. And my co-anchor, Cynthia McFadden, has followed the family ever since. Cynthia?
Terry, one of the things we learned over these years is just how little most of us really understand about the disease itself. I thought I knew a lot about Alzheimer's, but after Blaine and I took part in an experiment simulating what it's like to have the disease, I found out I didn't. It was 12 minutes that changed my life.
I love you, Mom.
Blaine Wilson's mother, LaWanda, came to live with him 4 years ago. He'd just married his new wife, Georgia, 5 weeks earlier. Blaine soon learned it was much harder than he thought.
Oh, God. Blaine! She's going to drop her car.
And later, she did. She lit fires. She wandered off. But LaWanda doesn't look sick, and she often seems fine, which makes it hard for Blaine and Georgia to understand how limited she really is. And that leads to frustration and resentment.
Just tell her to wash the clothes. I'm tired of washing. I bet you get her back, she knows what to do. Are you afraid? I mean...
No, I'm not afraid. You know, it's my mother. You don't understand.
The more we watched the tapes, the more it became apparent how little Blaine and Georgia really understood what was happening to LaWanda's mind. Do you really feel you understand the world your mother now lives in?
No.
What's going on in her head, her brain?
I have no idea. I have no idea. I need to understand that, Tim. I need to know what it's like.
Individuals with dementia say, we're hearing all this stuff and they can't turn it off.
Then we're each given 5 tasks to perform and only 12 minutes to accomplish them.
I'd like you to find the tie and put it on.
I can't hear you.
Blaine has a hard time concentrating from the start.
Your time begins now.
As he enters, Blaine is immediately disoriented. He staggers, reminding us of the way his mother looked on our tapes. Blaine tries to accomplish his first task, clearing the dishes off the table. But when he goes to put them away, he can't find the kitchen. So he gives up.
Well, I don't know where to put them.
Blaine finally finds the kitchen, but he can't remember why he's there. And again, the similarities to his mother were astounding.
She would open cabinets, and then she would shut them. Mother, what are you doing? Nothing?
But Blaine is doing a lot better than I am.
What the heck is this?
It's only about 2 minutes into the experiment, and the noise from the headset is driving me crazy.
God! So annoying!
As I try to accomplish my first task, find a white sweater, I work myself into a frenzy.
White sweater.
Remember, what I'm hearing is this.
No.
And believe me, it drives everything else out of your head.
Annoyed!
This is tough. I felt confused, kind of panicky. If I had to go through very much of that, I just might go crazy.
All right, that's not a sweater. That's not a white sweater.
I mean, you do understand why people start talking to themselves.
This is not a white sweater.
I was trying to organize my mind by saying, okay.
Okay. Okay. All right. All right. All right. Not a white sweater. Not there. I don't know about that.
You're doing great.
PK was in the room, and at one point when I sat down in frustration on the sofa, and she said, you're doing great.
Why don't you start with finishing setting the table?
And she told me what else I was supposed to do. I'll remember that.
The reinforcement.
Yeah, because you feel so alone. And you feel so frustrated, and there's no, you don't know what you're supposed to do, and it's so dark.
Reluctantly, I go back into the kitchen to try to find the plates.
Glasses. How long have I been doing this? About 20 hours? I'm not doing great. I'm not doing great.
And once again, I get distracted and go looking for that white sweater.
This looks good enough. This is like a, okay, it's not exactly a sweater. All right, I'll put it over my shoulders.
And I end up looking a little eccentric.
Her son's going to say, Mama, you can't go out like that.
Right.
You're getting a little off here.
God.
In the meantime, Blaine has moved on to the bedroom, where he's supposed to match 6 pairs of socks.
The hell? I don't know, man.
Instead, he starts folding everything in sight.
I swear, man, this is crazy.
By now, Blaine seems to have forgotten his list of chores. He was supposed to have found this tie, for example, and put it on. Instead, he folds it, along with everything else.
Shoot.
It reminded us of the time Blaine's mother set out to cook something for lunch, then got distracted washing dishes, and didn't remember until the pot was burning.
Plates.
After 12 excruciating minutes, the experiment was over.
I give up.
Blaine, your time is up.
Huh?
Your time is up.
Oh, shit.
What an unpleasant experience.
Damn.
Yeah.
I couldn't do anything.
Blaine was visibly shaken.
Yeah, what a way to try and get through each day. And kind of scary.
In what way?
Almost like panic.
For both of us, new insights.
It's a deep sense of confusion.
The thing that shocks me the most is that I couldn't remember 5 simple instructions.
I couldn't imagine living like that.
It's life-altering.
They need your help. They need your understanding.
So I guess the thought for me is that empathy or sympathy? What we just experienced there. So can he have more empathy towards his mom as a result of that? Yeah. It's interesting. We do experiential learning, sensory deprivation. We used to do this in CNA class, where they'd have us sit in a wheelchair and strap down one of our arms, put a blindfold on, some cotton balls in the ears, and do some sensory deprivation in order to feed, go through the motions of feeding a patient. And we did it in nursing school too. And that's such a powerful example, because you can talk about it all day long, but until you actually feel that helpless, you don't have any clue. I don't have any clue as to how that person feels. And it becomes very easy for us because we can go home. We can get up, leave that behind, and say, oh, poor thing, and walk away and go home to our own little slice of blah. But to the caregivers who have to stay there, it's tremendously stressful. It's like having your heart broken every day, over and over and over again. You can't do that. It's not humanly possible. It's not sustainable without taking breaks and without knowing how to compensate or how to deal with it. And sometimes that's the most powerful lesson, is being able to actually empathize from a point of view of experiential learning. I love that. I love what that guy went through. I love what he did. I loved more what the journalist did, because the journalist was annoyed. And she was a rather tall woman. I mean, if she got really ticked off, I could see her taking somebody out, right? Caregiver stress signs. So we talk about forgetfulness, poor self-care. We see this manifest a lot in the patients that we care for. Their caregivers are stressed out to the max. We wonder why the house is trashed. Well, the house is trashed because they're so busy making sure that that patient doesn't get trashed. And they've forgotten about taking care of themselves, because guess what? That's not a priority anymore. When I talk to my clients, I talk about you can't fill somebody else's cup with an empty one.
My daughter's not autistic and she's nonverbal. So like a lot of this is similar to what I go through.
Very familiar. Are you willing to talk a little more about it? Can you tell us your perspective on it?
I deal with that like all the time. There's times I'm so overwhelmed that I gotta like
step aside.
Right. And she's very behavioral, so she throws things, she hits me all the time, like, oh my God, it's a lot. Yeah. So, yeah, I can understand dealing with that. And a lot of like how they say like how you approach them, your way of like maneuvering around them is the same thing I have to do with her. Like, because you can't just approach her and you can't just touch her. Like you have to
sensory, right?
Yeah, and then she don't talk. So there's a lot of things that bother her that I have to like very clearly watch her to see what it is, because she'll flip out and I don't know why. But she can have like an ear infection or strep or whatever. Or just not feel good herself that day. And I'm like, still a lot. Like what I go through every day. I'm like, wow.
If you and this is just the sidebar, but there's a young lady who's profoundly autistic that her name is Carly.
Yeah.
Have you seen?
Yeah.
You've seen her channel?
Yeah.
Okay. Absolutely amazing. But thank you for sharing that. And here's the reality of what we do. You know what? We're all human beings. We all have been to that level where we've been so stressed out, beyond stressed, and we haven't seen an end to it. And to feel that helpless for that long it's difficult to process. So there has to be those, and that's where our volunteers coming in is amazing. Because you now give that, you give the caregiver a chance to go to the water bubbler and fill up their water bottle. Simple thing like that. And you give them, it's time to recharge. And we need that. We have to have it. But having that perspective, it makes you a better caregiver.
But they should have that for all disciplines.
Gosh, yeah.
I just retired from, working with all disciplines, autism and, mental health and all that stuff. And it's so hard for a parent because, not to be morbid, but it's like a life sentence.
Yeah.
And the same thing with mental health, with schizophrenia and different, bipolar and all that kind of stuff. It's so difficult. And again, they don't have, unless she pays for it, there's no help. She's got a lot of help, school systems and different things like that, but it's only for a certain period of time. The respite for her is not really there unless she dishes out money. And our society, doesn't see the respite that she needs and her family needs too. It's tough.
You just described the value of every one of us in this room and every person that's on this call.
We're backwards.
But we have a challenge before us, right?
Yeah.
Is to learn what we can learn from this and to be better at supporting the patient and the caregiver.
Whole country needs to change its philosophy and how we take care of each other.
And that's so true, because we get invited to things all the time, but I have to take a step back and be like, okay, well, we can't go there. There's gonna be 50 plus people, and she'll just elope, she'll just run. She doesn't know the sight of danger or not danger, so sometimes she's just jetting into the street, not even caring if cars coming by. So like, we can't go to a lot of things because it's too overwhelming for her.
It's too much.
Yeah.
So this is, thank you so much for sharing, both of you guys, because this is really important. A lot of times we're rush through our day. This is the time when we can actually get some perspective back. And sometimes these are the things that bring it. And it's not easy to watch. It's not easy to participate in or to listen to, but it's necessary. And it makes us better caregivers. And I will guarantee, because I've heard the stories, every one of you that goes in, Dawn, you and John going in, and Susan and Lori and all of them that go into patients' homes, every member of the care team is valuable to the individual and to the families. I hear it coming back to us all the time. Wow, that was amazing. Thank you so much. Gave me a chance to go out and get my hair done. Gave me a chance to go out and breathe, right? So thank you for that, both of you guys. So we think about some of the other stressors that caregivers are going through. We wonder why they're kind of stubborn and rigid, and they've got a lot of cynicism and sarcasm, and they're just a PIA, according to us. But there's always a story and always a reason behind the person who is unlovable. Recognizing abuse and neglect. So this is where our mandated reporter status comes in. As mandated reporters, physical abuse, emotional abuse, we need to recognize when it's happening. This population is prone to skin tears because their skin is fragile for one reason or another. Skin tears is one thing. Bruises over parts of the body that there should not be bruises on is another. Bruises in the shape of hand marks, where you squeeze when you're doing your transfer instead of going up underneath and hooking with your arm. Sometimes it's a matter of transfer techniques, just teaching, right? And that's another thing we can do, we can bring to the table. But we see physical abuse, we see anxiety and fear that happens when we have interaction with the patient and a caregiver walks in, and all of a sudden the dynamic changes, no matter what stage of Alzheimer's they're in or what stage of dementia they're in, their demeanor changes, and we see automatic escalation in that nervous anxiety. Those are red flags. Okay. Emotional abuse, that's a little harder. We're not there 24/7, we're there for 1 hour a lot of times, if that. Is the patient being subjected to psychological trauma? Are they experiencing post-traumatic stress disorder? Are they being belittled? Are they being secluded? Are they being put in a back bedroom? Even with the door open, if they're being put in a back bedroom and there's nobody back there with them, we have to be aware that if it's suspicious to us and we get that feeling in our gut, what do we do with that as caregivers and as volunteers? What do we do when we go into a house that's a hoarder's paradise? And there's cat and dog running everywhere, and there's excrement on the floor, and there's kitty litter trails all through the house. We've got mounds and mounds of garbage everywhere. Well, we've got options. Frail elder. We can file a report. We have Bristol Elder Services. We have Coastline Elder Services. We have options, but the chain of reporting is necessary, and it has to be timely. You can't just assume. You are just a reporter. What you see, you report, period. It's not personal. Okay? Financial exploitation, which happens a lot, where you now have power of attorney. And a patient's caregiver now has control over the money. And you see the patient's caregiver dressing a lot better than they did before they started taking care of the patient. Or they're driving a different vehicle and the patient's not wearing the best clothes. I've seen a lot of this. I've seen CNAs, no shade on CNAs because I was a CNA too, go into assisted living and rip these people off blind. And then the people who own the assisted living do nothing. It happened with my uncle. Saw it happen. Now, granted, the guy's carrying around a bankroll in his pocket. But still, you know, those things happen and they are happening out there. So we want to, if we see it happening, we have an obligation. It's an immediate response to your supervisor. Okay? Report what you know, what you saw, what you observed. Report the facts. Do not assume, just the facts. Skin tear, bruises, fear, money missing, filthy house, no food in the house. All those things are reported. Your supervisor then will take that and escalate that report so that it's now going to be investigated. We already broke, so we're gonna move on. You guys cool with moving on? We got an hour, but I want to try and wrap what we're doing now by 1 because I really want to hear feedback. And you guys have been really good about being interactive, so I'm thankful for that. And you guys out there in Teams land, minus Ziggy, can bring your responses too. I'd love to hear what your thoughts are as well. If you have anything that is kind of speaking to you in this, or that you've had experience or that you'd like to share, please don't hesitate to offer. Okay. So one of the things that we learn about in really in our nursing fundamentals class, I think, right? Nursing 101. Every one of us who are nurses that went to school for nursing had to go through Maslow's hierarchy of needs, because this is where the patients that we care for, this is a little window on something everyone has in common. Abraham Maslow was a psychologist who actually did extensive research on people and what allowed people to thrive and what happened when people didn't thrive. And the cycles of support that we have as human beings, all of us share these. The largest or biggest part of our foundation is our physiological needs. We all need food, we all need water, we all need air, we all need warmth, we all need rest, right? So safety, we need security, and we need to be safe. We need that sense of safety. We commune together. We stay in family groups. We get into townships. We get into churches. We go into family communities or communities where there is security, right? Then we go in belongingness and love, intimate relationships, friends. Some of us have been scarred traumatically, and we can't do this, and we isolate. But the mass majority of people will gravitate towards it. It doesn't stop us from wanting it just because we don't do it well, right? Esteem needs, prestige and feeling of accomplishment. Going up the ladder now. They're getting smaller, but they're still foundational. Everybody likes to know that they did a good job. There's a reason why you go for a course. You take the course. At the end of the course, you're evaluated for your learning. Did you learn something? Did you complete the course? Are you going to get a certificate for it? Just like you guys are going to get a certificate for your training. Okay? It's not like a gold star on the wall. If you cleaned up your area and you had nap time and you had your snack and did all of that like we did in daycare. Although it is kind of like that, because now Student of the Month. I recognize that. I thrive on that. I would love that, right? I never got it, but I would love it. And then finally, there's the thing called self-actualization. That means you've taken all of those things that were foundational at the base of that pyramid, and they've all built up to this place where you know who you are, You know where you fit in, you know what you're doing is valuable, and you are going to continue to expand on that in whatever field you're in. Alzheimer's flips this and knocks each block off systematically from the top on down. First thing to go, self-actualization, boom, gone. Second thing to go, esteem and needs, gone, boom. Belongingness and love needs, gone, boom. Finally, safety and security, I'll go out in the street and I don't care. I'll walk out the door and I'll just be wandering off. I won't feed myself, I won't drink, I forgot how to eat, I forgot how to drink. And then finally, food, water, warmth, and rest. Forgot how to do any of those too. It robs every bit of who we are as human beings. It takes it from us brutally. So reassurance. So this next video I want to show you guys is really, really cool. You've got these patients, people who go back to those earlier stages of development. Like you see the regression, like old people, like ancient people that you're caring for now are asking for mama. Because that's all they can remember. They don't remember that they're a mama or a grandma or a great grandma. They don't remember any of that. All they remember is their mother. What is mother to most people? Well, that's most people, and again, minus the triggers. Those who've experienced some really, really bad experiences, for the most part, that feeling of mom, I still remember what my mom smelled like. And I lost her when I was 11. I still remember cuddling with her. I still remember the feel of the polyester dress. Oh, that thing was stretchy and she shouldn't have been wearing it. That's besides the point. I remember those things, right? And I think back about that, and it gave me safety, it gave me comfort, it gave me feelings of belonging. When I was upset, she would comfort me. That's important because those are the last memories to go. How do you feel if you lost your child in a supermarket or in a shopping center in Walmart? All of a sudden you turn around, you told the kid not to go run it, the kid ran away, went right for the toys.
That happened actually.
Luckily, as a parent, you know where they're going.
Yeah, luckily
right?
it was only like a 2-second experience.
But their kid goes and looks around after they're there playing with the toy, and they look around and they're like, and then there's that moment where they realize, oh crap, Uncle, what happens in that child? That hot mess little ADD freak that just took off. Because that's where they're at, right? Say ADD. But they took off. The consequences weren't there. They didn't understand the consequence. Now they realize anxiety. It starts here, it goes right up, it goes up into their head, and panic takes over. You feel me? This is what we're dealing with. I want to go home. You don't have a home. You live with us. What happened to my home? I love my home. My husband's there. I got to go make him dinner. I know that was totally out of character for the 2100s. Right? I mean, the 21st century. I got to go Uber for him. What does the home in their memory look like? They remember from a kid's standpoint. You ever go to a place that you grew up in and you were just a little kid? You go back and it's just like, dude, what was the big deal about this place?
Right.
Like everything is just like, I feel like that when I go back to the school I went to when I was a little kid. Like I used to hide underneath the where they put all the chairs in the gymnasium. I used to go and explore there because my sister used to clean. I'm sorry?
The bleachers.
Yeah. And now I go there and it's like, it's dirty. And it's not that big anymore. It's kind of like whatever. It's anticlimactic for me now. But listen, all of the good, fun, wonderful things that you have as a child get sucked away when you become an adult. But your perspective is different, right? It doesn't look the same. And for the Alzheimer's patient, that place is not familiar anymore. It's a different thing. 50, 60 years before that's the memory they have. So what do? Habilitation therapy now focuses on environment. So it says, okay, I'm going to take this environment that this person is in right now, they're going to be living in, and I'm going to make it as familiar to them as possible for the time that they are familiar with. So this looks like it's straight out the 50s, right? Right down to the 57 Chevy. Oh, digress. It's a four. Is that a four-door? Nah. Yeah, it's a four-door. But that now is familiar territory, right? Maybe 95 years old, but that's familiar territory because that's what home looked like. I want you to see this. This is really, really amazing. So this is, just to cue this up for all of you guys watching over there too, just to cue this up, this is probably the best possible interaction I've ever seen with someone who suddenly has that I'm in Walmart, I'm alone, and I don't know where mom is moment. Best possible reaction.
So you said you found out a bunch of crazy stuff today.
Well, yeah, my God, I thought my husband was still living.
No, where'd you think he was?
Around. When they told me that he was gone, I couldn't believe it.
But you're okay though, right?
Well, I don't know.
You're okay, Graham. Graham, you're okay. Listen up. Here, give me the hand. We do the hand holding. Listen up. Fritz, you know his name, right? Fritz? Yeah. He's been gone for 6 years and he died in his sleep.
Who takes care of me?
I do.
Before you come.
No. Oh, you've been living with us for 2.5 years. And before that, you came up to our house every weekend for about 4 years.
Who took me up there?
We did, Pete and I. You came to stay at our house every weekend until you couldn't live alone anymore, and then we moved you in permanently.
Oh my God.
So you used to know every day. You just forgot. You forgot today.
What did he die from, honey?
Well, probably heart failure. He had Alzheimer's disease, but when people die in their sleep, they usually have a heart attack, you know? So he probably had a heart attack in his sleep.
I thought he was still living.
Well, if he was living, he'd be by your side.
Well, I thought he was around.
You're stuck with me, lady. So I know I'm a distant second to Fritz, but I'm better than nothing.
Oh my God, honey.
I'm better than nothing, hey? It's okay, Graham. It ain't easy getting old.
And learning the truth.
It's fun to be surprised that you have a beautiful little great-granddaughter, Jazz, every day, but it ain't fun to be surprised that you lost your husband every day, is it?
No.
No, that's bad
I loved
news.
him dearly. And I thought he was still around. We're old.
Yeah, we'll get your mind off it. We'll take you home and get your mind
I'll get my mind off it.
Yeah, you'll be okay.
I'll have a bottle of beer.
There we go.
And get my mind off it.
Perfect.
You bet. a chance to see this or to check out the rest of the story, it's pretty fascinating. Just what are your thoughts on that? Like how did you perceive what she did with her? I'm curious to know that from you guys' point of view as well. Go ahead, Don. I know you want to speak.
Yeah, I mean, it's obviously very, very sad, but the granddaughter seemed to continue to bring comfort to her by affirming facts and then causing her to think of something else.
So tone, matter of fact, facts, and understanding that he needed to kind of be reassured, right? Replacing a positive with a deficit, I think is probably the thing that steps out to me the most, right, Don? Yeah. So I think that when you see someone who's dealing with this, that question's probably going to come up, or that realization's probably going to come up 4 or 5 more times that day. And every time, I'm going to go have a beer. By the time she's done with 5,
Yeah.
I'm just kidding. But this is the kind of thing that caregivers need to learn. She didn't lie to her. She was compassionate with the truth. I think the emotion and the anxiety that's built up after being under duress for so long, the truth comes out, but it's not kind and it's not compassionate, and it's usually dictated by the emotional flow of the moment, right? And this is challenging for our caregivers. This is challenging for us, and certainly challenging for our patients too. And if we can kind of take some cues from this, that I love the fact that there's more time and effort and research going into this disease now than has ever been. And there's more hope for at least halting or delaying the onset of a lot of these symptoms. Those medications I gave you, that report actually outlines a lot of those things that are happening right now. There are medications that are designed specifically right now that are available to patients that you may see them come across in your starts of care if they're on trial, or if they've been taking them for a period of 3 to 6 months. You're going to see where those medications that are being used are actually helping them to arrest cognitive decline. But it's different pieces that are needed. For this person right here, this lady, she didn't just need medication. She needed the psychosocial component, the emotional component that comes from a family member who loves you and learned how to deal with the stress of this whole mess. And that's how we do as well, right? So person-centered care. Every person is unique. And we know that. Some of us more unique than others, right? Focus is on the person and not on the disease. As clinicians, it becomes really challenging for us because guess what we do as a nurse? Give me a nurse's perspective on caring for an Alzheimer's patient, Ashley.
I feel like it's multifaceted, you know?
I'm sorry?
I feel like it's layered.
It sure is.
You know, every moment is a little different.
So my care plan for that patient is going to be specific, measurable, achievable, relevant, and timely. So when I get to achievable and relevant, the middle of that continuum, right? I have to figure out what's most important and what that patient is capable of achieving. Now that takes I have to step out of the situation a little bit to do that. But inevitably, I'm still a human being and I still care. My level of caring as a nurse is going to still care, but objectively, I can come in and I can set some things up for this patient and this family that are going to absolutely exploit the opportunity to keep them at a quality of life that is going to honor them. I'm going to give coping mechanisms. I'm going to give rational goals for both, ones that are going to be able to be achieved. Now, I know it's different for you guys. Supportive care is way different than traditional. The traditional approach is way different than supportive care. Ours is to get them up, get them rehabbed, and get them home and keep them out of the hospital. Yours, like 180-degree focus, right? So I get that. The principles are still kind of the same. And that's just from a nursing standpoint. From a volunteer standpoint, what is your objective for somebody like this, Don?
As a chaplain,
Yeah.
yeah, I want them to feel secure spiritually and to know that, you know, that they're loved and that there is a presence with them that is above themselves.
Yeah. So the faith component is a core piece of us.
Yeah.
Whether we have it or what we have it in, it's still important. And that piece, you're coming at it from that point of view, and their reception of that is going to be drastically different than their reception of what you're offering them. But they're going to work together, and that not one is not more important than the other, and at least from our point of view, right? Focuses on the person, not the disease. Behaviors are communication, and person-centered care can reduce caregiver stress. Thank you, Don, for that. Thank you guys for letting me pick on you. Person-centered care, what's right for the patient? What are the triggers? I know this patient. I've taken care of this patient. I know what's going to trigger them. Okay? I know what they don't like, and at their level, where they're at right now, I know what is not going to be therapeutic for them. I know what calms them down. Don, there you go. We're now appealing to faith, which is in the core, and will bring peace a lot of times to folks, right? That's the one piece that now transcends all the other chaos that's going on in their life. Knowing their history can help tailor care plans. Absolutely. We got to know what they like. We got to know what their strengths are. We got to know what their weaknesses are. We got to know developmentally, where are they at in their course of their disease. And then habilitation therapy, we already talked about this, but I want to reinforce this with you. It does not restore function. That is not the objective. Just as the objective is not to keep the patient out of the hospital, well, it kind of is, but not to help the patient become healed from whatever they're going through right now. It's to help them be able to gain quality of life as they go through the progression of that disease process. It does help to maintain mobility. It does help to maintain dignity, and it does help to maintain plasticity. Now, that term I've used it a couple of times, neuroplasticity. Plasticity simply means that if you got something that's plastic, is it moldable? Yeah. Can it be molded to a shape that is functional? There you go. Plasticity means that you can mold whatever's going on to a shape that's functional for you at that moment. So a basic understanding of personal safety makes personal care time difficult. We know this. Watch for cues that someone may be at their limit. Like you guys right now, after you've heard this for 3.5 hours, hello? And you haven't torched me up yet, so I'm thankful for that. You guys, I could go like this all day long and you wouldn't be able to do a thing, so it's all good. Respect the need to stop here. My agenda stops with that patient's anxiety and agnesia begins. Habilitation therapy actually is a process that will feel more natural to a patient if you're hand under hand. And we showed an example of that with the eating, right? Accessing those parts of the brain that still have memory attached to the action. that main memory might be gone, but there's still pieces of it left in there we can connect with. So again, care, we try to time our care and our visits with the time that the patient's going to be awake. If we go to there to do a visit and the patient is pashkaga and they're sleeping, are we going to be effective? No. So we learn the routines, we work with the caregivers, and we try to time our visits so that they coincide with the times that these patients can actually do what we ask them to do. To get up and do ADLs, to get up to have some, to be able to get up to the chair, whatever. Are there songs that they like to sing? Do they like music? The next video we're going to see, actually, there's a couple of videos that are still left I want to get to, that talk a little bit about how music transcends all of the mess and the loss and the chaos that's going on in the brain. And it can trigger and connect points of the brain with lucidity that wasn't there normally. It's like music for some people. Music now reroutes through all of the damage and connects these points of reason to where that person all of a sudden becomes their personality again, instead of that depleted, reclusive, inward-focused individual. So a lot of times what happens with this population of folks, and I gave you this because I think it's important not only for the patient, but it's also for the caregivers. This right here is an activities book for people with dementia. And there's a lot of really cool activities in here that you can do, from cooking to window boxes, to memory boxes, to memory quilts, okay? A lot of times what will happen is, though, they're available out there and you can buy them like off of Amazon or whatever, those cognitive blankets where they give little things to keep the patient active.
Blankets.
I'm sorry?
Like the cozy blankets. Or like the apron or something?
No, ones that have stuff on them that you can
like
play.
the buttons,
Yeah,
the
yeah,
zippers.
yeah.
I love those.
Those right there, though, they can be counterproductive too. Because when the patient can't figure out how to do it, it becomes very frustrating for them, right? So you have to kind of know your patient, right? But if that patient was a vavo who liked to work in his garden and loves growing things, and now you got a chance to help him with a window box, and he's still kind of in the first couple of stages of that disease, what better way to channel that energy into something that he loves to do? And something you can share in. The kids can come in and help with that. There's a lot of ideas in there. Cooking. People who love to cook, you got to be a little more careful with it because if you, but it's still therapeutic and it meets them where they're at, and it's something to connect the caregiver with the patient. So really, really cool stuff that's available. It's basically using their capabilities now and giving them a chance to explore them all at that level. We can use activities that draw from past experiences in their life, things that they used to like to do, that now reconnects those pieces of the memory in their brains. Stimulate the senses without overstimulating. Okay, I'm gonna bring puppies in, but they're all Jack Russells. Why would I do that? They like puppies, but Jack Russells, man, that's too much input for me, man. And then you cross them up with a Cocker Spaniel. I know this because my daughter has one. He's crazy. Spin around, script. Every time I see him, he pees. Return movement opportunities without taxing them. We know our limits. We know their limits. Don't push them. Like right now, I'm kind of pushing your limits. But I'm almost done. We're almost done. Yay. And you can eat. Language and conversation, sensory movement, art, discovery, music. Music is a big one. Music is amazing. Tony Bennett, Lady Gaga, could not be on more opposite ends of the spectrum. Yet Tony Bennett had advanced Alzheimer's. He couldn't remember his own name. He didn't even remember how to walk. But when someone led him over to a piano stool, and put his hands on the keys, and man started to croon, and he went right back to singing. Just amazing what will happen when you have something that you deeply love for so long. It's still there, just connecting the pieces. So we have some pictures here. I want to show this one to you. This is the power of music. This is really a cool video. And I'm so glad I was able to get through this to this point where you guys are going to get the full Monty for this program. Because sometimes I don't make it through. Or I talk too much.
Hi, Papa. Hi, Papa.
Huh?
How you doing?
I'm all right. I'm fine. Wait.
Who am I?
I don't know. Wait a minute. I don't know.
Okay, it's Cherry.
How long has he been in the nursing home? Approximately 10 years. He was having seizures, and my mother couldn't handle him at home. Of course, it affected me greatly because he was always, fun-loving, singing, every occasion he would come out with a song, no matter where he was. I remember as a child, he used to walk us down the street, me and my brother, and he would stop and do Singing in the Rain. He would have us jumping and swinging around poles. He was, he was good. He was always into music, always loved singing, dancing.
His name is Henry Dreyer. And I'm looking more or less for religious music for him. Because he enjoys music and he always quoting the Bible. So I'd rather have that for him.
We first see Henry inert, maybe depressed, unresponsive, and almost unalive.
Henry.
Yeah?
Henry.
Yes, y'all.
I found your music. You want your music now?
What do you want me?
Let's try your music, okay? And then you tell me if it's too loud or not.
Then he is given an iPod containing, we know, his favorite music. And immediately he lights up. His face assumes expression. His eyes open wide. He starts to sing and to rock and to move his arms, and he's being animated by the music.
And he used to always sit on the unit with his head like this.
I want to say that's the doctor from
He didn't
Awakenings.
really talk to much people. And then when I introduced
That's the
music
doctor
to
from
him, this is his reaction ever since.
Awakenings with De Niro.
The philosopher Kant once called music the quickening art, and Henry is being quickened. He's being brought to life.
Yeah.
I'm going to take the music for 1 second, okay? Just to ask you a few questions. Okay?
He's like, what are you doing?
You're going to give it back.
Like, yeah, I was jamming.
The effect of this is when the headphones are taken off, Henry, normally mute and virtually unable to answer the simplest yes or no questions, is quite voluble.
Henry.
Yeah?
Do you like the iPod? Do you like the music you're hearing?
Yes.
Tell me about your music.
Well, I don't have one, I mean.
Do you like music?
Yeah, I'm crazy about music. You play beautiful music, beautiful sound. Beautiful.
Did you play music when you were, did you like music when you were young?
Yes, I went to big dances and things.
What was your favorite music when you were young?
Well, I guess, Cab Calloway was my number one band guy I liked.
What was your favorite Cab Calloway song?
Oh, I'll be home there for Christmas. Oh, you can count and plan on me with plenty of snow, mistletoe, present wrapped around your tree. Ow!
So in some sense, Henry is restored to himself. He has remembered who he is, and he's reacquired his identity for a while through the power of music.
What does music do to you?
It give me the feeling of love, no man. Figure right now the world need to come into music, singing. You got beautiful music in, beautiful, oh lovely. And I feel the band of love, the dream. Lord came to me, made me holy. I'm a holy man. So he gave me this sound. I'll just say, I meet you. Let me see. Rosalie, won't you love me? Rosalie, won't you be sweet and kind?
With this beautiful new technology, you can have all the music which is significant for you in something as big as a matchbox or whatever. And I think this may be very, very important in helping to animate, organize, and bring a sense of identity back to people who are out of it. Otherwise, music will bring them back into it, into their own personhood, their own memories, their own autobiographies.
It's amazing, right? What did you see that was most important that you would take from that video? What was the one thing that you were able to see in that video that was just absolutely remarkable to you? Sorry, what was that?
When you like lit up with it live when you first heard the music.
The absolute complete change of affect, right? You go from being a person who's withdrawn and sitting there, and it'd be really easy just to ignore them and think they can't communicate. Maybe it's just because we haven't told them something they want to hear. Absolutely. Anybody else? Straight up, right? That is like the coolest thing, because that came from just playing a song. And then he comes out with this lucid perspective on what the world needs. That struck me. I was like, wow. If we took all the summation of all the wisdom of all the people who are suffering from Alzheimer's and we brought it to bear, how much better would our world be? Think about that. It's amazing. And you think about, we look at AI and we look at all these other things as being such tools, but between that, social media, and everything else that we deal with has isolated us more than we've ever been isolated in the history of man. It's just such an it staggers me, man, when I think about it. Like, I miss my dad tremendously. I miss my mom. I miss my grandmother, my aunts. Those people who have gone before us, because I can't go back and tap into what my history is through them. How many volumes of history have we lost? That makes this precious, right? So precious. Just
All these tools, like the iPods and the stuffed animals that have hearts that beat, and like all these types of techniques should be in every facility. And they should just be tried on patients. And then if we see that reaction, then we give that to them.
Yeah.
And we shouldn't even ask. It should just be in the facilities, but they're not.
Well,
Not only that, but then you have people who just don't even care. They don't care to do that.
Well, it should be part of the habilitation in all units, and not even just for dementia patients and Alzheimer's patients, but just in general for people who, have to be in facilities and things like that, because it might be depression and things like that, but just as a whole and part of, their budgets. And again, it's a philosophy I have.
It's a good one. It's a good one. Because here's the bottom line. The reality of our world right now is fiscally and financially centric when it comes to care. It always has been, and it's not gotten less. Not going to say better or worse, because it's kind of gotten better because we're now more accountable for what we can deliver. But our activities people, they are so important. And some of them are like, wow, but they're really hugely important when they bring these tools in. I think I hear what you're saying is that it would be a lot better if all of us who are caregivers had that recognition and were able to say, okay, maybe we could try this. Maybe I hook them up with a set of headphones and we see how they respond to it. Now, some of them might not. That's the reality of how far gone a lot of folks are. But there are some who would. And why not try? We spend too much time, I think, trying to fulfill quotas and productivity. That's a word that gets thrown around a lot for us as nurses and physicians. And it's the nature of healthcare. It's not endemic to one place. It's the nature of healthcare.
No, it's an overall, and we're stuck in so traditional ways that we're not looking outside the box. Yeah. And if we did these things, it would also save money in other ways because we wouldn't be paying for medication and we wouldn't be paying for other things because the person at their, even in their stage, would be healthier because they wouldn't need other medications to pain, depression, anxiety, and all this other. So in the long run, it would also save money and they'd have better quality of life at that time.
Absolutely agree. Absolutely agree. Your thoughts, folks, on what we've watched in that video and just all together, because this is kind of the time that I wanted to open up for the next 10 minutes or so. I've given you guys the access points for your exam and also for the evaluation. Those links are within the email invitation that you received. You just got to click on them and complete them. Once you've completed them, they come directly to me. So that, I don't need to do it right now. You guys can do that when you go. But right now, this is debrief time. I want to give you 10 minutes or so for us to kind of chat and kind of reflect back, because it's easy to fire hose this for 3.5 hours. But that's pointless from an education standpoint. I'm not about just delivering information. I'm about actual practical application. And if we kind of inspired some things with this information, I'd like to hear. So, the floor is open.
Tim, during the break, Tim, you mentioned, I heard you talking about specific diets that possibly help and vitamins and such. Can you just give a little summary statement on that?
I would absolutely be happy to do that, because I was having a chat at the end of the table, and this is where I get my happy place from. So if you take a look in the report, the NIH report, there's a section on page 9 that actually talks about some of those non-pharmacological interventions for people who have Alzheimer's and for prevention. If you run into the risk, if you fall into those categories of risk factors. And it's fascinating to me that we've had this information for literally over 100 years. We've had the information, but because of one reason or another, it hasn't taken priority when it comes to overall health and indicators. A lot of people don't realize that metabolic health is tied directly to Alzheimer's risk. If your metabolic health is not up to standard because of lifestyle choices and uncontrolled conditions, then you're more at risk for higher incidences of inflammation. The more inflammation, the more intracellular inflammation, the more prone you are to the formation of plaques and that whole glutamate cycle. So here's the bottom line, and I know that was a long explanation, but I wanted to preface it, what your question was, with some of the background. Lifestyle counts. It's not the whole thing, because there are some aspects of this. It's so multidimensional, the discussion on Alzheimer's and dementia. You can't just nail it down to one specific thing. But I'll tell you what, if I can alter my diet to reflect a better approach, then maybe I'm going to do that. What do you think? I can control that, right? This is actually on, yeah, it is on page 9. It's under the behavioral, lifestyle, and other interventions. And I'll read this real quickly to you because I love the way that they put this. So multiple lines of research find that several forms of non-pharmacological interventions may also offer promise in reducing dementia risk factors and improving cognition and memory. Results from randomized controlled trials indicate that interventions with blood pressure control, hearing aids, multivitamins, and personalized health coaching can reduce dementia risk in specific populations, but more research is needed. And that's where NIH investments are starting to go. For example, one recent NIH-funded study sought to maximize the potential of Tai Chi in slowing mild cognitive impairment. Simple body movements and exercise, right? This recent study compared the effects of traditional Tai Chi, which consists of physical movement and breathing exercises, to cognitively enriched form that adds mental puzzles and challenges. So now you're always giving an opportunity for the brain to kind of expand and to get stronger. Neuroplasticity, right? Here's the part about the diet. NIH researchers also are continuing to build on past scientific discoveries on the link between diet and dementia risk. As one example, NIH-funded investigators found that individuals who consumed a modified Mediterranean ketogenic diet composed of 5 to 10% carbohydrate, and I want to be really clear about this, that 5 to 10% carbohydrate content in your diet, the average American is consuming way more carbohydrates daily than they should. Like they're 200, 250 grams of carbohydrates is not unheard of in the American diet, 300 and upwards. If you have high triglycerides and you're taking in a lot of sugary, salty, fatty foods, well, not salty, but the fatty foods, the ones that are not necessarily good fat, you're now adding to your body's ability to be inflamed because the body reacts to that. This is what they found. A diet that consists of 5 to 10% carbs, good carbs, not the simple carbs, but the more complex carbohydrates, 60 to 65% fat, and that's not the bad fat. That's excluding saturated fats, that's excluding the LDL fat and cholesterol, that's enhancing the HDL, which is the high density lipoproteins, which essentially is avocados, walnuts, anything that's high in omega-3 fatty acids is usually going to be a source for good fat. Increasing those amounts in your diet. 30% protein. They did this for 6 weeks and it had significant changes in both blood and spinal fluid biomarkers associated with Alzheimer's risk. Specifically indicate individuals following this diet exhibited improvements in several risk factors, including increases in beneficial high-density lipoprotein, or HDL, cholesterol, and reductions in body mass index and systemic inflammation. This study is the first exploration of diet-related metabolic changes in spinal fluid and provides evidence of the effects of diet on modifiable risk factors. So those are the ones that we can change. Not the ones that are genetically hardwired, but the ones that we can change. Is that helpful for you, Don?
Yeah, thank you. That's interesting.
It's fascinating because all right, so now here's where I'm going to challenge you. I want you to do an audit, and a lot of times docs will do this, nutritionists will do this. Do an audit of what you're eating in any given day and be honest about it. Okay? Most of us, we graze without thinking. We're emotionally controlled in our food choices. We're eating fast foods because we don't have time to sit down for a meal. And they're profoundly unbalanced. We're also having high levels of sugar, caffeine, and other substances that are keeping us fueled up for the rest of the day. If you look at it and you do an audit and you measure it against what this recommendation is and change it, see what happens to your cognition and your body mass index.
Interesting.
Fascinating stuff. Fascinating. And this is in our control. We can control that now. While there's no cognitive decline, while there's no cognitive impairment, we can do that as individuals. And I would say that caregivers need this information. They need to know that they have control over keeping themselves healthy. Because if they aren't healthy, what happens to the patient? Right. Great, great. I am so glad you asked that question, Don. So glad. Anybody else? Any other questions or
Thank
comments? Videos are awesome. And there's more than that. There's more than that. Actually, in the annual, we go over it. There's another video where this lady is just, she's an expert in the techniques that are used to kind of reach people who are unreachable. And she uses touch, she uses sound, she uses tone of voice. And it's just so remarkable what can happen when you actually are intentional and you take the time to be able to implement some of these strategies. It's really kind of cool. Yeah. Any other questions, comments, anything that you're concerned about? Okay. All right. So you all have the links. I am going to give you a couple of days to fill that out. Click on the link, complete the exam. Once the exam is completed, I will get it directly. Okay. Please complete the evaluation because it helps me to get better. I focused a lot more on the practical application today. And that's my course correction because I spent way too much time on the A&P the last class I did, and they let me hear about it. Well, one of them let me hear about it. So, and that's good because that's how I grow and that's how I bring a better product. Okay. All right, and I guess that's it. Was everybody able to open up those attachments that were sent? You guys were able to open them up and download them? Okay. You can put those into a file if you ever want a resource. Those are all really great resources on everything having to do with Alzheimer's. Like I said, we just crammed in an 8-hour training program into 3.5 hours. And we're also going to give you have adjuncts. If you're a volunteer, you have a list that I included that are videos that you can go over to satisfy the modular component. The rest of you, CNAs and nursing, you guys have Relias modules that need to be completed to complete and get your certification. Or not your certification, your certificate. Okay? That's it. You're free. Go eat. But remember, modified Mediterranean keto.
Thank you.
Have a good one, guys. Take care.
Okay.
Thank you.
Bye-bye. Thank you.
On email. The documentations. You're a great one. Thank you.
I have to go to the grab something. First unit. And then we'll be back here again on Monday. Yeah, so that's why I figured that, right? The middle one is when you go in the door, you go straight. Go through the other door, right? Thank you, Tim.
Thank you.
Tim.
Thanks so much, guys.
Send me the other one.